populations in the US. It has been widely recognized that high OOP is the main cause of inequity because only the rich can afford to pay for the better services. And for those population that is at the lower socioeconomic group, in order to enjoy the better services or, or newer therapies, they have to come up with their own financial resources and leading to financial hardship, which is we often happens like selling their properties or stopping their kids' education in order to pay off the medical bills. Financial hardship, in more modern term, we call it financial toxicity. You hear a lot of this if you go to literature. And because of this reason, WHO recommends that the OOP should not exceed 40 to 60% of the current health expenditure for all the countries. Now, this slide shows the general increase in the trend of healthcare expenditure as percentage of GDP. So you can see over a period of about 18 years, from year 2000 to 2018, there is a very clear upward trend of healthcare spending. And on the top of this is the US. They are the top spenders in the world. Zooming into Malaysia, Malaysia is also increasing in healthcare expenditure. So over a period of about 4 years, the expenditure in terms of GDP as I said earlier, out-of-pocket expenditure is most common in the less well-off countries or more rural countries. Malaysia, being an upper middle income country, should not be spending that much. We are almost spending very close to other countries like Vietnam, Laos, Philippines. And most worrying is compared to other countries where most of everybody is decreasing in their OOP, whereas Malaysia is increasing from 2010 to 2014. So there's a very obvious increase over that 4 years, and the trend is still continuing. So that's healthcare financing model. What about demographic transition of the population? We see an increased prevalence of non-communicable diseases, or NCD, because of the population aging in Malaysia. And also, we see a lot of successes in reducing mortality from other causes. So all this will lead to a growth in aging population. So how is this to be a worry for us? So you look at this graph, you can see that the life expectancy of Malaysians is increasing over a period of about 40 to 50 years. So we are, both male and female are living longer and longer. In terms of aging populations over the year of 2012 to 2016, you can see there's an increasing trend in all of the states of Malaysia, perhaps except Sabah. Now, this slide actually carries a couple of very important messages, and they are all varying. First of all, let's look at the gray bars. This is the bar representing the age group of 65 years and older. So you can see over the years, from 2012 to 2020, over a period of 10 years, there's almost a 5% increase. And then, sorry, more than that, is 40% increase in the age population. However, if you look at the population from 10 to 14, there's a clear shrinkage. The percentage drop is about 5 to 7%. Now, this is worrying because in 10 or 15 years' time, this population will move into the taxing population. What that means is there will be less people who will be paying taxes. So if that is going to be true, the source of healthcare financing is a problem, because where do we get enough money if the taxes shrinks? So that's for healthcare expenditure and financing. Let's move on to demographic. Let's move on to diseases. So this is a slide showing the prevalence of diabetes. So Malaysia has a very clear increase in diabetes as a country as a whole. So back in 2011, the prevalence about 15.2, but then 4 years later is 17.5. So a very quick increase in prevalence of diabetes. In terms of prevalence, you can see that compared to other countries, Malaysia has a very rapid increase in prevalent diabetes over a short period of time. This is blood pressure, hypertension. While we are okay relatively compared to other countries, the high prevalence, relatively high prevalence, is still of very much of a worry. For cholesterol, Malaysia is definitely on the high side when compared with other ASEAN countries, presumably due to our sedentary lifestyle and the dietary habits. So all these, worries that I talk about, reduce healthcare budget, aging population, and change in demographics, and all the change in epidemiology, etc. We have a lot of undesirable outcomes. So what are these undesirable outcomes? It can include universal healthcare being jeopardized. Equity can be affected because, as I said, the lower socioeconomic populations have to pay out of pockets, and therefore leading to financial toxicity or financial hardship. And the overall end result of all these problem will be an non-sustainable healthcare system in Malaysia. So with all this, there are a lot of questions arise. Include, is the level of spending sustainable? Are we paying the right cost for the service? Are we able to maximize the benefits with our spending? Up to this point, you may think, you've been talking about spending. So does that mean we have to just keep on spending or spending more and more, and that would help taking care of a problem? It's not. It depends on how we utilize the money, or whether the healthcare resources are used wisely. Let's look at this slide, which shows life expectancy and the world ranking of in terms of the life expectancy. So as I said, the U.S. is the #1 spender in healthcare in the world. However, in terms of ranking and expected in life expectancy, is only at 46. Malaysia is here, and we rank 112. Another country that is high spender is the UK, and is ranked only 38. So what that means is, doesn't mean that you spend more and you'll be able to live longer or improve in all the bioindicators. So this is where this new concept, value-based healthcare, comes in. Value-based healthcare is nothing new. It actually started back in 2010 when President Obama put out this new act called Affordable Care Act, or ACA, otherwise known as Obamacare. Value-based healthcare is in simple terms, is just moved from the traditional healthcare system of providing quantity as much as possible. Now we have to switch from quantity to quality. So in a nutshell, it's a paradigm shift from quantity to quality in healthcare provision. And this is probably a more sustainable way of providing healthcare. The Institute of Medicine has developed the so-called STEEP methodology to describe what healthcare or high-value healthcare is. It includes safety, timely, efficient, and effective, equitable, and most importantly, it has to be patient-centered, because quality of life of patient is of utmost importance. So for value-based healthcare, we should not be paying a fee for service. Instead, we only pay for value. I mentioned about the healthcare white paper in Malaysia put out earlier this year. There are 4 major pillars. And the third pillar is exactly on what I have been talking about in the past 15 minutes, is ensuring effective and efficient healthcare spending. So, ladies and gentlemen, I'd like to conclude my presentation by the following points. Universal healthcare is at stake in Malaysia due to change in population demographics and scarcity in healthcare resources. The way healthcare is financed at the moment must be restructured. And last but not least is healthcare should be measured in terms of value rather than cost. So with that, ladies and gentlemen, I thank you for your presentation.
So it's good to see that advertised. So I've been in Malaysia now for about 16 hours, I think, so far. So I've experienced a lot of hospitality and not a great deal of sleep so far. But hopefully I'll make a degree of sense this morning. So first challenge is to make sure that the slides move on. Nope, not yet. Do you want to test that? Sorry. Oh, now we can really, yeah. I thought it was going well, but now it's going really well. You know, we're really at the top of our game now. And yeah. Oh, thank you. There we go. It's okay. We have no slides, but at least we have a lectern and that. So. Thank you. Okay. Hooray, there we go, right. Okay. Oh no. It wasn't me, I promise. No. Take a step back. Too high. Is that better? Yeah? You can hear me? Okay, great. Okay.
I'll just push that across. Yeah. But probably you need to ask them to move through the next one. If that's okay. Yeah, you just need to tell them next.
Will do. Okay, are we ready? Okay, so we're not going to use the pointer because it's causing too many problems. We're going to just move manually. So I'll just let you guys know when to move to the next slide. So just to introduce myself, my name's Scott Rutherford. So I currently work in Dubai, where I've been for the last 18 months or so, as part of a new integrated academic healthcare system, which is being set up in the UAE in Dubai. But my talk today will be mainly on my experiences in the UK and Ireland, where I've sort of tended to work in either government roles, trying to set policies, or funding bodies, trying to fund university research and innovation. And I've worked in universities as well, and both in a sort of London, a major city, and also in a sort of more kind of civic and more community-oriented kind of setting in Belfast in Northern Ireland. So I wanted to talk a little bit about some of the policies in the UK over the last few years, and if I can, maybe just try and hint at a bit of a shift towards a more inclusive approach to innovation. So we'll move on to the next slide, if that's okay. Next slide. Okay, so just a few more sort of theoretical slides, maybe just to sort of set the scene. So like a lot of kind of Western economies, I guess the UK was quite seriously affected by the financial crash of 2008, and that sort of productivity chart, so all the things that go into an economy and all the things that are produced out of an economy, since the crash in the UK, as I said, and in a number of Western economies, has been really, really flat. And trying to kind of move that blue line up to the green line where the productivity growth should be since 2008 has been really at the heart of a lot of the policy making. So how can we make sure that the sort of productivity of the UK through policy gets back to where it should be? Because that gap is a huge loss of wealth. It's in the trillions of pounds of money that has been lost through the lack of productivity that exists in the UK. So a lot of government focus is on trying to close that gap. So just go to the next slide. But at the same time, while the government has tried to sort of address those kind of productivity gaps, those kind of problems in our economy, it has led to these real kind of cycles of virtuous kind of success, where some parts of the UK economy have really boomed and really grown during that period. It's also led to a real kind of series of places and areas of the UK that have seen a huge kind of area of decline, and that has been across lots of different kind of reasons for that, I guess, both in terms of whether there's been a bit of a breakdown in the social kind of fabric in some of these areas. There's been a lack of investment. There's been a sort of loss of skills in those areas. And part of the issue is trying to work out how you can kind of grow economies and sort of put value back into the system, while at the same time not leaving some of these places kind of cut adrift, because a lot of these places have seen productivity continue to decline. They've seen their health and their wealth being outcomes adversely affected, and they've seen a real lack of leadership in how they can try and sort of tackle some of these issues. So that is the sort of reality, I guess, of some of the outworkings of what has happened in the UK economy. So if we just move back to the next slide, please. And I guess why are some of these important in policy making? Well, it's because some of these things really matter to a lot of people. The amount that people are paid, the amount, their level of education, and their life expectancy, etc. All these are, sort of pretty key indicators of how people feel. And as you can see, these are sort of regions of the UK, major regions of the UK across the bottom of these charts. Each of those little dots are some of the sort of sub-regions or local authorities within those bigger regions. As you can see, there's huge amount of variation, both within regions, but more importantly, across some of these regions. So if you're somebody in the southeast of England, in those kind of, Oxford, Cambridge, London kind of golden triangle, as we call it, your life expectancy is generally much, much higher. Your pay is certainly much, much higher. Your attainment at school, etc., is much, much higher. You compare that to some of the northern parts of the country, the sort of northeast, northwest, etc., where pay and living standards and health outcomes are far, far less than in some of those other areas. So these are real indicators that really matter. Moving on to the next slide, please. So R&D and innovation, I guess, has always been what my background has been in, and it is absolutely part of the solution to some of these areas, some of these problems. The more that businesses adopt innovation, the more that they can link in with universities, for example, the more that you can sort of get innovative and more disruptive technologies into businesses, the more those businesses grow, the more people that growth is in those regions. But it's also part of the problem in the UK. So the UK, in terms of investment in R&D, you've got a breakdown across business, higher education, government, etc. And you can see in those different regions that actually there's a vast concentration of innovation funding on the back of the policies that the government has introduced over a number of different decades. And that concentration arguably has built really world-leading institutions who would be kind of, top of any league table in terms of universities. But at the same time, it's left a lot of those regions behind. There was a really important report done by Nesta, which is a UK think tank organisation for science and innovation. And what they kind of said in their report was that there was about a £4 billion gulf in terms of the quantum of funding, I guess, in terms of those areas that have R&D funding, have a lot of innovation funding, and those areas who are much, much lower down. And that really was quite a seminal kind of report in the UK 4 or 5 years ago, and it sort of changed a lot of the sort of thinking around how R&D and innovation policy in the UK should be implemented and funded moving forwards. I'm going to try the slide clicker. Who knows what will happen next, but we will go. There we go. There we go. So some of the kind of more different economic theories at the moment that are particularly influenced Irish government policy has been this idea, and this is an academic, Kate Raithworth from Oxford University, who's talked about this idea of sort of donut economics. A lot of you might have heard of this this kind of theory, and it's kind of saying that this this kind of drive for more growth. All governments want to grow their economies, want to be bigger economies, want to create more wealth, etc. And these have led to us putting huge amounts of pressures on the environment, on the kind of biodiversity, and in terms of the effects of climate change and air pollution, etc. And it kind of puts a limit. There's only so much that you can do to keep on growing and put that amount of pressure on the planet. And then at the same time, it kind of leaves like a missing hole in the middle where the sort of social foundations of these policies, the inequality that those policies have driven, have left a lot of people kind of adrift of the system. So that kind of idea that there is a kind of policy-making sphere that exists as a sort of concentric circle, I guess, there, that ensures that you can live within that kind of confines of what our planet can tolerate, as well as what the sort of foundations of a fair and just kind of society are. And that's what her theory really is getting at. Now, it's early days. There'll be a number of people who say that actually, growing economies creates the wealth that can then be kind of redistributed across different parts of the system. But there's equally a lot of evidence that actually hasn't happened, and a lot of areas are left well kind of adrift of some of those other areas. But it's just one theory that I think is beginning to influence some of the policies, both across Ireland and across the UK. And that kind of leads me on to the It was nearly there. There we go. Kind of leads me on to this kind of another kind of theory, I guess, around this idea of more inclusive innovation. I guess innovation that is maybe not necessarily framed by that kind of Silicon Valley high technology view of the world, which has created a lot of benefits undoubtedly, but as I said, has left a lot of people adrift. And this idea that actually maybe you can be more inclusive and more participatory, I guess, in how you drive innovation policy and how you execute innovation policy, both in healthcare and lots of other different sectors as well. So that idea that you have much broader involvement in the decision making, you have much more co-development, I guess, and co-design of the funding instruments and funding policies that are utilised. And there's some academics at King's College. I would advise you to look at some of their publications, some of their papers, and they've talked a little bit about how, exactly as I said, it's not just a Silicon Valley kind of view of technology, and that governments and policymakers and funders should sort of challenge some of the thinking. Does all the money have to go into the southeast of England or those major kind of leading institutions? Is there a role to say, well, actually, that there is a much more balanced view around what innovation means and the sorts of differences that some of these regions need? I'll skip over that slide just in the interest of time, and we just move to the next one. So in terms of some of the sort of government policy actions that I've been involved in the UK, I think that there has been an important view actually that innovation hasn't meant that much to a lot of people in our society. I think that's important thinking moving forwards. It's not always enough to just grow economies in certain areas and leave these areas kind of cut adrift. It's critical that innovation is meaningful outside of just the worlds of academia or outside of just the worlds of these sort of clusters that are performing so highly. It's got to mean something to a broad bunch of people. I think there's definitely been much more geographical spread of funding. Government has a target that approximately half of the money over the next 5-year funding cycle will be invested outside of that sort of Oxford, Cambridge, London kind of triangle in the UK. I think what's really, really important just in terms of how innovation is delivered as well in the UK now, it's done much more through local autonomy, much more local leadership, local empowerment is expected, and that goes right from local authorities and councils and civic leaders right the way through into community groups, etc., in different parts of the local society. And making sure that there's joined up approaches. You need your urban planners, you need your transport planners, you need your universities, you need the private sector, you need your community activists, etc. Those people need to come together and form these kind of delivery vehicles that have got a much more inclusive, I guess, approach in terms of how they are delivered. So I thought I'd just end the next few minutes, if there's time, just with a few kind of more practical examples, I guess, of some of the things that are taking place across the UK. I think that there are some colleagues from Scotland here, actually, from Strathclyde and Glasgow, and I've taken this example from here. So this is a kind of brand new, kind of high-tech, kind of sort of science innovation park, I guess, which is being built adjacent to the airport in Glasgow there, an extremely poor part of the city, which is just across the riverside here. And in designing this new kind of advanced manufacturing innovation district, there's been a very inclusive and joined up approach in terms of how that space is used. And it is a blend of some extremely high-tech innovation centres, both in medicine manufacturing and in sort of advanced manufacturing more broadly. But it's also then a huge amount for local skills in the people who live nearby, and in trying to bring together kind of much more renewable energy and sort of carbon net zero approaches. That the entire site aims that it will be carbon net zero. And a lot of the sort of transport links getting into the site are about trying to bring the local community into that sector. Moving on to the next example, this is a new health innovation campus which is being built. It's a 10-acre site in Birmingham, which sits in between the kind of university and one of those yellow blobs, and then the sort of hospital area in the other blob. So it recognises that there's something that this needs to literally bridge the gap between the sort of healthcare delivery systems and the academic institutions. And this is very much a kind of civic-led initiative in a region of the UK that has got a lot of racial kind of mix in that area, and a huge amount of deprivation and sort of poverty as well. So how they can make this more relevant, I guess, outside of just the university walls, has been a key part of their thinking. And there's been some work done in the local NHS system around some of the digital health technologies, where they've formed these kind of community-based kind of co-innovation groups. And that might be something that you want to think about in your, in the development of some of your ideas moving forwards, is how you can work and co-design with people who maybe don't always have a say in what these products or what these services might look like, how you can get more honest kind of answers. There's a very interesting kind of peer research, a kind of training model that they've used in the NHS in this part of Birmingham, where they've really tried to get more honest responses from the people who aren't, adhering to some of their diabetes treatments, or who aren't, accessing the kind of mental health apps. And actually, it's not just kind of barriers around age, it's barriers about sort of family structures, workplace, etc. And that need for sort of simplicity in design and in usability has really come through in that example there. And then finally, maybe just one of my kind of former universities, Imperial, which has done a huge kind of regeneration effort in the West London. Again, a very, very kind of mixed area of the city with some real pockets of kind of deprivation. And Imperial is kind of seen as being this sort of South Kensington base, sort of near Knightsbridge, near Harrods, all that sort of kind of high-end stuff, I guess. But actually, the last 10 years of the journey there in London, in terms of what Imperial's done in the White City area, has been a real regeneration. So it's not a gentrification. It's not just putting up expensive university buildings, etc. It's about bringing in, key worker accommodation, mixing that in with some of the incubation and the innovation facilities, and then have a whole dedicated area which is about sort of local community outreach, helping, kind of the elderly part of the population there, ensure that they're au fait with sort of digital technologies, that they have maker spaces, they have after-school clubs for the local students, and both at secondary, primary, and at university level. So a real kind of effort there to make it a much more inclusive kind of environment in what is one of the world's kind of leading universities. So finally, then, I thought I'd leave with a quote there, obviously, which just kind of says that some of the, as I said, the pursuit of sort of growth agendas have definitely led to more kind of unequal, parts of the society, in the UK, and actually maybe a different way of sort of tackling some of these issues, maybe a different way of thinking about the role of innovation is going to be important moving forward. So just to leave with a few key kind of takeaways, I guess. So maybe just think moving forwards how innovation works, not just for the few, but for maybe for as many people as possible. Recognize that sometimes this pursuit of growth all the time hasn't always worked in a lot of Western economies, and actually maybe there is a different way to frame some of the thinking around how policy is developed in terms of research and innovation. Think a little bit about the importance of place and of partnership, and how you can get as many people, I guess, involved in some of the decision making, some of the thinking that goes on in terms of innovation. And just to say that there are some real key examples now in really major kind of cities of the UK as to how they are really bringing more inclusive approaches in terms of how they are driving innovation. So hopefully I'm broadly on time. I wanted to just finish there and say thank you for listening, and thank you for sort of bearing with us with some of those technical issues that we have earlier. Thank you.
Thanks so much for that, Scott. And next we have Dr. Dewey Juliana, and she's a medical officer from Sultan Ismail Health Clinic, where she has 20 years of experience in public health and healthcare and management. So really excited to hear from you. So come down, Dr. Dewey.
Hello, hi everybody. Okay, good morning, everybody. I'm glad to see you are here today. And did you know that actually we had spent more times by commuting, and in America they spent about 11,000 hours per lifetime for commuting, and it is equal to 450 days. And maybe we can do something. We can do something else that we can make that time more efficient and more enjoyable. Okay. Actually, when we talk about the transporting, we have to ensure that everyone has an easy access to the clinic or to the hospital. And there are two categories of the patients, which are the one needs the emergency transport, and another one non-emergency. Okay. This is, for example, this is not the by policy, but this is what we call it some initiative for the TB patients, for the communicable disease patient. This is actually from the Malaysian Association for the Prevention of TB, MAPTB. This is not the government, not from the government. That actually they provide the financial support to the patient, TB patient that he needs, and the medical officer actually will fill out the special form and submit to the MAPTB for approval. And actually, we plan to end TB. And actually, for the TB patient, they need to come to the clinic every day to check the medication. Okay, so there's two. So they have to come every day for the intensive dose, and then that one is for 2 months, and then for the maintenance for another 6 months. Even we have the video observation of the treatment, but they still have to come to the clinic every week. So to those patients that have so not come from the that come from the have a financial problem. So the MAPTB will give some allowance, 100 ringgit per month until they finish all the TB treatment. Okay, next is actually the park and ride. This is from the Johor State Government, and it is a collaboration from the Johor Public Transport Corporation. And this will they offer the free shuttle bus service from Malaysia, and they were involved 2 main hospitals. The hospital Sultanah Aminah and the hospital Sultan Ismail, and also involved 2 main nearby health clinic, which is Mahmudiah Polyclinic and then the Sultan Ismail Health Clinic. Actually, For the hospital Sultan Hamina Health Clinic, it actually begins with the main terminal bus, and the patient will come and make their way to the hospital, and then they can visit to the nearest health clinic before they head back to the bus terminal station. All right. And for the Sultan Ismail Hospital, it is convenient because it is located at the near hypermarket, and they can it making easily accessible, and the patient will come to the journey and then can just go back to they can going back to the hypermarket. So this is actually commencing on 2022, and the frequency actually every 15 minutes in the morning, and after start from 2 p.m. So the service is actually for every 30 minutes until 6 p.m. So actually we have another one. Okay, this is a policy for the emergency treatment. This is called pre-hospital care and the ambulance service. This is a policy where developed from the Johor Health Department for the pre-hospital care and the ambulance service for and ambulance service. This is called PHCAS. And actually, Johor is the one of the 13 states in Malaysia, and it is located at the southern region, and also share the maritime borders with the Singapore to the south, and to the west and east they share with Indonesia. And actually this policy was developed to provide this very systematic approach, integrated pre-hospital service and high quality care, okay, to ensure efficient patient handling. And those patients that need the treatment, we will continue the treatment until the patient arrives at the facilities, the nearer facilities, whether it is a hospital or it is the health clinic. And the scope of pre-hospital care, it is actually involved the emergency ambulance service for interfacility transfer and referrals, and emergency call handling, which we call is as MERS. Okay, MERS 991, Malaysia Emergency Response Service. This is the unifying Malaysian emergency numbers to the one central numbers for easily access. And the last one is disaster response on the mass casualty incident, MCI. And for the ambulance response team, the first respondent is actually from the assistant medical officer and the driver. It is not from the doctors. Doctors just stand by at the clinic. If if there's a serious injury, then they call the doctor on call to come and assist patients to the hospital. And then, of course, the pre-hospital care, we operate for 20 hours per day. The hospital will operate 24 hours, and the health clinic will operate from 8 a.m. to 5 a.m. However, there's still a person that on call. So, as I mentioned earlier, the first team response is the assistant medical officer and the driver. But then, if the patients involved is the maternity patient, so they will call the nursing from the maternal unit for assistance. Okay. So actually, for the situation that we had a confusing regarding the function of the ambulance service in the various operational zones, so that we have the MECC, Medical Emergency Coordination Center, that serves as a reference center. And the ambulance driving is actually governed by the policy on safety of ambulance land of ambulance, Ministry of Health, that published in 2019. So in the situation, in the situation where the next of kin of the victim does not have vehicles at that time, and asked for the right to the ambulance, actually it is subject to the permission. And if it's approval, they should fill up the indemnity form for ambulance passenger, MOH, Ministry of Health Policy on Safety of Land Ambulance that published in 2019. Okay, this is an initiative from the health clinic. Every year, the Ministry of Health will have the convention, the innovative convention, and this is one of the projects that won the third place in the innovation convention in 2020. The problem is actually poor adherence to the clinic appointment, which is 74% only. This happened to the one of the rural area. There's no Grab, there's no bus service, only have a taxi, but this is too expensive. And most of the people there is elderly. And when we do survey, most of the problem why they not attend to the clinic is due to the transportation problem. This is about 35%. So what they do is they did the intervention, they introduced the ride and guide. So where they provide the transport is from the community, use the community transport. But then they realized that the area is still poor, okay, the first cycle. And then they did the resurvey and found out that most of the people there is partially dependent. Okay, so most of them, since they are elderly, so they need the assistance. Okay, most of them are walking with walking stick, mobile with wheelchair, had a partial hearing impairment, have the sight impairment. So what they did though, so they provide the guidance. And the patients actually have to pay for the service, but not to the clinic. They pay for the persons that help them to take the patients round trip. They come to the home, brought to the clinic, and helping the patient to register, and then bring the patient to the doctor's room for consultation and ending with the pharmacist. Okay, so if the patients need to come to have the refill medication, we let's say the appointment of the doctors for the next 6 months, but patients still need to refill their medication monthly. So for the refill medication, they still use this clinic right intervention to send the medication going to home. So this is a plus minus service with the clinic right. This is what we call Relamed. They are the winner for the innovation convention also in 2023. So the problem is patient didn't come to take follow-up to refill medication. Okay, this is they did the innovation at area. This is also the one of the remote area, and most of the patient also must plus minus same with the previous clinic rights population. Most of them are elderly. And this objective is actually to enhance the continuity of the patient's medication supply. So the target is at least 90% of the patient will pick up the medication, and they successful get the more than 90%. Same with the clinic, right? Previously, so after the intervention, the adherence to the clinic can catch up until 95%. Okay. Okay, this is the for Relamed. All the intervention was published in the Journal of Pharmacy Quality in 2023. And Malaysia actually has come up with the aging population few years earlier. We expected in 2030. And to promote active aging, the person have to move more and more. So to enhance the life satisfaction among elderly, older people, and for the quality of life, to enhance the social integration. So the game changer is transportation, actually. Okay, that's all. Thank you.
Thank you so much. And now we have Dr. N.M. Kamal Abdullah, and he comes from the Sultanah Amina Hospital. He's got 15 years of medical and healthcare management prowess. So he's going to talk to us about his practices in healthcare. So come on up.
Thank you, Prof. Lisa. A very good morning to everyone. It is a privilege for me to speak to the esteemed faculty of Taylor's University. As a representative from Sulaiman Kasih, I'm excited and a little bit nervous to share with all of you regarding our mission for sustainability of healthcare. Sustainability of healthcare through partnership and social responsibility. Okay, this is a previous. Okay, this is Sulaiman Kasih logo, and we do believe that the power of small act can transform the world. I would like to inform all of you that we have Sulaiman Kasih have 120 volunteers, with various background, and emphasizing the backbone. The committee comprises of 18 medical doctors, hold a strategic post in the Ministry of Health Malaysia, in the southern region of Malaysia, including the hospital directors and also the deputy directors. Okay, I want to show all of you. This is the most important pictures for Sulaiman Kasih. This shows the crucial moment for Sulaiman Kasih during pandemic COVID-19. And they are from various backgrounds. There are teachers, lawyers, engineers, some of them from the private sector and also the public sector, including me, myself, from public hospital. We are so thankful to God with the presence of this noble-hearted person. We can undergo the pandemic COVID-19, and we start produce DIY PPE ourselves. At that particular time, there's none in our stock, and there's a disruption of supply chain. There's a close of border, close of factory, but Alhamdulillah, we managed to produce 1,000 sets of PPE per day to meet our hospital demand. Okay, this is a picture of a pandemic, our group during the pandemic COVID. Next. Okay, we believe by crafting a good policy for healthcare sustainability through public-private partnership, we can ensure that the sustainability of healthcare is possible by a good collaboration from public and private sector. I want to show all of you this smiling picture of a couple. Okay, both are engineers, come to help us sewing the PPE. This picture shows that not only women can handle the sewing machine, okay? And this also shows us that men can also handling the sewing machine. Okay, this is the example of policies for Ministry of Health. Okay, there's a 1996 policy, the back white color, and then there's a revision in 2005, and then the latest revision in 2003. Next. Before that. Okay, policies are dynamic. They are adapt over the time to address new challenges. Okay, next. Okay. For our vision, Sulaiman Kasih, to create a sustainable, efficient, and equitable healthcare system through a strategic collaboration between the public and private sector. Next. And our mission is to improve the healthcare infrastructure and access, enhance the quality of care and patient outcome, promote sustainable practice in healthcare operation, and ensure the long-term financial viability of healthcare initiative. Next. Okay, the engagement of stakeholders is very important to make sure that our dream, our objective is met. Okay, we will involve the public sector, the private sector, and the community in all our effort. The public sector will be public hospital, primary healthcare clinic, government healthcare department, and regulatory bodies. For private sector, there will be the private hospital, pharmaceutical companies, health tech firm, and also NGOs. Next. Okay, for public-private partnership, our concern, our focus in terms of infrastructure development, service delivery, capacity building, and funding and resources. Okay, for the infrastructure development, there will be joint venture for building and upgrading our healthcare facilities. Okay, for the service delivery, there's a collaboration between the private and public partnership. And for the capacity building, there will be a training program from the private and public joint venture, and also the funding and resources. For the funding, we aim to create a pool of funds from public and private partnership. Next. Okay, if we're talking about corporate social responsibility, we'll focus on community health initiative, sustainable practices, patient support program, and also innovation and technology. Okay, Sulaiman Kasih make a move. Okay, Alhamdulillah, we signed an MOU between Sulaiman Kasih and Taylor's University in the early this year. Okay, where there's a transfer of knowledge and technology, where there's an involvement of academician students led by Encik Yusri. Okay, and Sulaiman Kasih, me, myself, and also Dr. Yad, and in the public health hospital led by me, and where there's a project between Sulaiman Kasih and also Taylor's University, where we focus on mental well-being research. Okay, there is an involvement of the psychiatrists in Hospital Sultan Aminah Johor Bahru. Okay, next. Okay, next. Okay, for the implementation strategies to make sure that our objective meet, okay, there will be a regulatory framework, incentive and support from the team, and monitoring and evaluation, and also capacity building and training. I do believe that in all aspects, if we work as a team, there's nothing impossible and we can achieve the outcome, the good outcome. Okay, next. However, there's a few challenges that we face during the first 5 years of our operation. The issue with funding, okay? But we try to overcome this issue by a good collaboration between public and private. There's a pool of fund, okay? Regulatory hurdles, regulatory problem, which usually associated with a stiff and strict guideline from the Ministry of Health, okay? And the stakeholder coordination, but I do believe there's a good collaboration between the stakeholders. Okay, next. Okay, to end my speech, okay, by implementing a robust policy, integrating partnership and social responsibility, we hope that the healthcare will be sustained and give a very profound impact. With that, thank you.
So before you sit down, I would like our speakers in the first session to come back up, actually. So can we have the two doctors, and Scott and Leo will be asking you some questions, and we encourage our audience to ask some questions of our speakers in this session. Go for it, Leo.
Sure, thank you. Do you have a microphone for test? Yeah. I'm just going to hand it to you, Scott. So, thank you so much, all the speakers. Unfortunately, Prof. Kenneth couldn't make it to the Q&A session. He had other commitment, and we asked the presenters in the hall to join the Q&A session. So, with that, I can lead the question, but I would like to open it to the audience and to our students to start with questions from the audience. I've prepared my question for you, but let's see if there is a question among the audience. So, who's going to go for the first question? There's a special prize for that. Yeah. Can we have a microphone for the...
Hello.
Hello? Okay. Hi, so my name is Karen. I'm a medical student at MBRU. And my question is for Mr. Scott. Thank you for all the speakers for your time today. I was wondering, since you have your experience in the UK and now you have moved to the Middle East, what's something that you have seen before that you think these guys are doing it right? Let me bring it here, that we can somehow incorporate that into the challenge that we're working here in the symposium and the bootcamp as well.
So you mean in terms of taking other ideas from elsewhere and bringing it into the Dubai context? Yeah, I mean, I think that's always the trick, really, is obviously there are lots of great areas of the globe that are doing fantastic things, but you also have to adapt into a particular context. You can't just do a copy and sort of paste and expect it to work. So I think, certainly some of the things that I've seen in Dubai the last sort of, kind of 12 to 18 months, I think there's a very, each of the different areas that you would expect in a functioning ecosystem is there. All the, the sort of, funding elements, the delivery elements, the support for businesses, the incubators, the accelerator plans, all that's there. I think what we're trying to do at the moment is to make sure that is all properly joined up and coordinated. So if you're someone with an idea, an entrepreneur wants to start a business, that support is not a difficult path to navigate and that it's joined up. If you're somebody who's overseas who wants to come to Dubai, it's a great place, by the way, and wants to sort of, grow your business there, if you want access to the healthcare system, the patients, the data, etc. How can we make that journey as joined up and as coordinated as we possibly can be? Because there are plenty, in my experience, there are a number of good ideas and great kind of new ventures, but they don't quite get the
joined up level of support that they need to really get their businesses going or get their ideas off the ground. And that's the thing we want to really avoid in Dubai, is where, you know, great ideas don't get the kind of end-to-end kind of support which we, you know, kind of, you know that those businesses need. So hopefully gives you some idea about what's happening. Thank you.
It does. Thank you.
Thank you, Scott, and thank you for a wonderful question. I can take one more question from the audience, and I want to ask my questions. Yet, one at the front. You can also address your question to any of the presenters that we manage the mic, or you can ask general questions.
Yeah, I guess this can apply to all of you. So I'm Gemma, I'm from Melbourne Monash University, studying industrial design. This was more focused to you, Scott, but I guess if all of you have an idea for it as well. Across your experience, what's your favourite ways to tackle helping solve solutions for people who aren't involved in the process? Especially in the health industry, you're not always going to have what you're studying, so what are your favourite ways to tackle those things?
You have the mic, it's okay. I'm going to put them on spotlight, but go on.
So you mean, so you're talking about sort of ways in which you can use sort of processes to try to kind
your
of better
processes
service.
that you use.
Yeah, I mean, I would say, you know, first and foremost, you know, healthcare is always more difficult. You've got, you know, often you've got, you know, your clinicians, your nursing staff, your other professionals, you've got your kind of academic staff, so people that don't, you know, naturally always come together, you know, that easily. So I think, you know, ways in which you can create time is often one of the sort of most sort of challenging issues, and then often, you know, when you're trying to reach other, you know, other stakeholders within that ecosystem, I think, I don't know if you've heard of these kind of, you know, sandpit ideas where you maybe have a little bit of a kind of seed funding or something like that, which sort of brings people in around the table. So, you know, where you're getting lots of different stakeholders to focus on a real kind of challenge. I think actually a clearly identified problem is often, you know, often we have lots of solutions that aren't really tackling a problem, or people don't really understand what the problem is. So I've seen some great kind of sandpits and kind of aim studies where you sort of aim for a particular kind of targeted problem, and then try and get as many of the different stakeholders in the room as you possibly can. So yeah, it's not easy. I've also done some work in sort of in the sort of clinical trial space, where often you expect people to come to particular facilities. It all happens in one place, and sort of work in ways which you can get a lot of that kind of treatment and sort of analysis done actually maybe closer to where people are. It actually breaks down barriers, you know. So even introducing sort of buses that can go to these different places has been really important as well. But I don't know if anybody else wants to add anything or no.
So on that, I have two specific questions. I think I'll shoot one for Dr. Camille. My question is, how can policymakers ensure the involvement of all of the stakeholders in sustainable healthcare policy development? Because some of your examples were from like collaboration, community, private, and public sector. But how we can ensure that, and how we can, from the policy perspective, look at this, you may say, hurdle?
Okay. To make sure that the policy, okay, there's an engagement between the stakeholders, okay, the public, private, and also the community, to make sure that the policy, they follow the policy. We must make sure that the policy is clear, and the policy is not static. It can be transformed, and there must be revision when there's time needed.
Yeah, perfect. Thank you. And first, I'm aware of time, and I'm just going to have my final question from Dr. Julian, and that would be on the barriers. Like you mentioned some of the barriers that you faced in the initiative that you have, but to be more precise, what are the key barriers to implementing sustainable policies in the healthcare sectors, if you can share that with us?
Yeah, actually, now we are in aging populations. So once aging populations that I touched about the transport just now. So by aging population, they need to mobile actually. They need to mobile, but most of them stay alone. Students, they nobody to bring them going somewhere, and they also had a partially dependent. So means that some of them use walking stick, use wheelchair. There's a hearing impairment and also some other impairment. So that's some of the barriers that we need to overcome, actually.
Yeah, thank you so much. I think this is directly lead to one of the basically topic that we're going to focus on during the study tour, which that would consider accessibility. I mean, the service might exist, but then how to make sure that the target audience or people in need or basically the patient have access and the equality is in place. I think with that, we're going to thank all of the presenters for their first session and proceed to the second. Thank you so much. Thank you.
Thank you so much. Many, many inspiring presentations there. And I love the quote about we can't get out of these situations with the same thinking that we got ourselves into them with. And also that it takes not just one person, but a whole village to solve these problems. So our next panel is all around educational approaches. And our first speaker in this session is Dr. Ib Junpapan, who is going to speak to us today about her research, which is in cross-cultural design and design for well-being. So welcome, Ib. She's coming here from Thailand, Chulalongkorn University.
Is it working? Okay, thank you. Hello, everyone. Thank you for having me today. So today I stand before you not only am an educator and a designer, but also a lifelong learner who passionate in design, in the intersection of design and healthcare. And before I begin my presentation, next slide, please. I would like to take a moment to acknowledge each of every one of you who came here today, and your presence reflects a commitment and to advance the sustainability of healthcare. And I'm truly grateful to be here and to have the opportunity to have an important questions and conversation with such a dedicated group of people. And I recognize that the journey toward healthcare, the better, the healthier society of healthcare cannot drive by just one person. It needs a whole village to drive an innovation. And in order to do that, to drive the world where the sustainability in healthcare is not just a goal, but it's just a way of life. So we need all together from every discipline to do this job. So thank you so much for being here. And in the next 15 minutes, I will be talking about 4 issues. And this begins with the examining an educational approach that aim at fostering the sustainable creativity, exploring how the approach can contribute to the promotion of the sustainability of healthcare, because the sustainability of healthcare can be empowered by the creativities and the problem-solving skills that every one of us, whether disciplines that you are coming from, will be need this skill, and how can we do that to sustain those kind of creativities to solve this kind of complex challenge. And in the next topic, I will be talking about the case study that we've been doing at Chulalongkorn University between the design school and the psychology school. What kind of approach that we gave our students, and what kind of tools, what kind of methods and principles that we teach them, and how do they learn from it. And in the final issue, I will be covering the challenge and the opportunities that coming from the methods and the principles that we've been using in the last couple years. So this is from what you have seen. In the future of healthcare, there are you in it, the future generations who are helping us to create the sustainable of healthcare. But what we've been facing, especially in Southeast Asia, Thailand specifically, there's gaps of the communications between the professional healthcare practitioners and the designers. So within this context, so there is a demand for the continuous creativities that coming from both sides. But what can we define, what kind of creativities that gonna emerge in this context within the complexity in the healthcare system? So the complexity in the healthcare system come from like cultural context, like different perspective, or even like a work environment context, because between next slides, please. Thank you. Because between the healthcare sector and the design sector, we have our own language, or we have our own methods to process things. Like we both are an expert in our own way. And when you speak directly to like health professionals, and you are a designer, and you try to let them know that, oh, there is a more possibilities to work with, or how you can visualize it, it can be challenging from both sides, like how you're gonna communicate in the same languages. And on top of that, there's still like the problems about like the approach that we use to communicate the health knowledge, especially in Thailand. Sometimes when talking about the health promotion, we take the didactic approach. Like if you ask somebody, oh, you have to lose some weight, so you have to take like 2,000 steps, but their strength might be something else. So that might be challenging to do, like to communicate between these two sectors, like how to promote like health effectively. And so our mission in Thailand, especially in the education sector, so we want to create the sustainability in healthcare. But in order to do that, we need to cultivate the culture of the sustainable creativity also. And the sustainable creativities, we started within the educational sector. And this is going to be the questions that I will be answering throughout the slide. And we're going to start with what do we teach from the curriculum design that we are managing within the resource that we have. And then in the slide today, I will be talking about like how our design students and how our psychology students learn from this kind of methods and what we already been achieved. Next slide, please. So within the design educations, so it's come from the questions like, if we want to create like a better and innovative solutions for healthcare, or like what kind of health and education that I already have, like all those kind of healthcare challenge, they're not like a static fields, but they're more like a multifaceted challenge, and it's always evolving. So within those areas, in order to do so, you need to embrace the cultural difference and to have the cultural competence to understand the difference between different backgrounds. And what we want to, and this might be like a common language that the design students might already have heard of, that what we teach is we teaching them to have like a creative thinking for problem solving, but the tools that we have to template them, it needs to be understandable and easy to digest for the people who coming from the non-design backgrounds as well. So that's the key. And the pedagogy that we encourage them to learn from our sessions that we host for the design student and non-design students is supposed to be the way that everyone can be involved. So it needs to be collaborative. And in order to have collaborative sessions, so you need the tools that everyone can have a chance to exchange their ideas without having a judgment. Next slide, please. So this is what we doing at the moment. So there is a subject that I would like to give an example for. This subject is called the psychology of happiness. It's been taught in the Faculty of Psychology at Chulalongkorn University. And so in general, this course, they basically focus on the theories and the principles of the definitions of happiness, like what kind of happiness that that people gonna feel or think, like how do you perceive the ideas of happiness and how you maintain those happiness in a day-to-day life. But the thing that are lacking from the course is that with the knowledge of the psychology that the student have, they can actually produce some more like innovative ideas that can bring the that can explain how can we have how can be happy to somebody else in the society as well. But because so normally when you go through the theories, so you just taking notes and asking some questions, but you cannot transform it into like a visual form. And when I ask them what is the design solutions, if you want to explain to someone how to make yourself happy or how to make your friends happy or how to have self-love, they have a hard time picturing what kind of design solutions that I'm talking about. So so the thing is, and they're not so sure that they have the creativity enough to create the design solutions. So we create like a template or a guideline to help with the non-design students to understand what kind of design solutions that can help them meet the healthcare needs. And so this has been researched that what the healthcare needs are, and we create this guideline to help them picturing what kind of design solutions that it must be. So we told our design, our psychology students that design can be product, service, system, and experience, and that give them some ideas to proceed with the next step of the creative methods that we are about to propose to them. So in the next step, we believe that a sustainable future of healthcare require a positive thinking. So instead of using the deficit-based method that we've been told to use in like a health sector or a design sector, so instead of focus on like what the weakness, what the problems, and what the barriers are, we focus on what is the strengths, what is the capabilities that one person can do, and we start from that. And in today's sessions, I would like to give an example of the tools that we've been using to emphasize the strengths of the individual users or help the students to learn to have an empathy toward the stakeholder and the user. So the tools is called Extreme User. I guess some of you have heard about this tool before. So everyone, I believe everyone in this room, we both extreme in some kind of way. But when I go to talk about the design solution or give the design, try to introduce the design methods to a non-design student, so I come up with some examples, like for them to explore some more and try to find some relationship with themselves as well. So an extreme users that I give an example, there are two categories of the extreme users, and I think you will find in your study tour later on as well. So the first kind is the a confused koala. So within a confused koala, they seems confused with everything. They don't have heard of this topic before, but on the optimistic side, the confused koala, they love to explore something new and learn from a friend. And the second category of the extreme users is the sleepyhead lion. The sleepyhead lion doesn't want to do anything, like he had a hard time finding an inspiration and motivations to do something. But if the sleepyhead lion keen to do something, he will do it like a full-time job. And the last extreme category of the user is the hard-to-please cat. So the hard-to-please cat is like a perfectionist, like the cats know very well about what she wants to do or what she wants to do, but so it's more like an expert side of the user that you have to please with the healthcare needs or what the needs of the design are. And so when I give an examples of these 3 categories of the users, it's helped the psychology students to relate to themselves. Oh, I have this behavior before, or I have this mindset before. And then we help them create the mission through the template called Jobs to be Done, which is from the design thinking as well. But instead of create a mission that's purely from the designer side, we kindly ask them what kind of strengths you are, what kind of like things that you like to do, what kind of friendship that you want to nurture, or what kind of self-love in your mind is. So we focusing on the strengths and what they nurture the most. And apart from what I've been speaking to, we also bring our design sessions to the cross-cultural level as well. Thanks to Lisa and Leo for helping me inspire this idea and have the cross-cultural workshops in Thailand for a couple years now. So we got the participants coming from like multiple countries in Southeast Asia. And it's been interesting experience to see like the diverse perspective come all together just to help promote the health and well-being. And I think this is like a great opportunity that everyone, not just only the designers, can come together and try to look from the different perspective and learn from and have the design mindset, not just for the designer. And so I would like to summarize that in order to nurture the sustainable creativities and to create the creative confidence, so you need the power of the perspective, and it's a collective effort that you cannot do it alone. Like as a designer, you have like an experience or you have a skills in design, but from the health professional, so you have a content and it's a power of the data. So the way that you work together, you have to see each other as a co-designers, not just I'm a designer, I'm a professional. You have to work together, and the way that you need to communicate each other, just to try to speak in their languages, try to understand them and listen to them, like from both sides. So this can help bridge the gap between the health context and the design context. So, so far, there was a challenge that came across when we do the design education for the sustainable healthcare. So the question is like how to turn the collective effort into like a program development cycle. So now at Chulalongkorn University, we've been integrating the idea of the sustainable healthcare and the sustainable creativities into the existing course. And we wanna develop it further and create like a general course for everyone from public to enter the course as well. Because so far we have seen so many opportunities like a students-led initiative and innovations that coming from this course because they have a chance to work together. And some of the students-led initiative are not just limited to an app, so it can be like an event or it can be like an experience, something like that as well, because of these collaborative efforts. And what does all of this tell us? So I would say like the positive design-based approach can serve as a platform for the students to collaborate and exchange the ideas and embrace each other's differences. And with focusing on when we're focusing on strengths, so this will be like more possibilities opening up to you, and you can. And when you try to like encourage somebody to like promote the health or solve the complex challenge like mental health, for example, it's better to speak to them in a positive way. So I would suggest that focusing on what kind of strengths that it's already there, it's already have. even in the darkest side of the user that you might encounter in real life. And the second things that tell me in my experience is the effective communications and the co-creations are crucial for developing healthcare solutions. Like, it's good to get the right questions asked, but it's also essential to get the right people to answer you and understand your languages. And the third thing is creative sustainability can be like a cornerstone. So we need to nurture it. Like, it's not just within the designer, it's in everyone. Because the healthcare service deliveries, it's complex. So we need to, like, it's gonna be a long run for you guys to solve this problem. So we need a group of people. It's a group effort to do this. And I would like to conclude my speak as an educator, as a community member, and as a culture enthusiast that I am reminded that this is like an immense responsibility that's shaping our minds for the next generations like you. So we have the power to inspire everyone to think critically, creatively, and compassionately about the world around us. So if this presentation can be helpful, or you need somebody to help with the positive design-based methods, so please feel free to reach me out, and hope your project next week gonna be helpful and fun for everyone else and for the society as well. Thank you.
Thanks so much, Ib. And our next speaker also comes from Thailand. We have Dr. Chaithon, or Paki as we like to call him, Limaponovich. And he is the head of the institute at the National Innovation Agency, and he looks at foresight. So welcome, Paki.
Okay, hello, good morning, everyone. Thank you for having me today. May I have my presentation, please? Okay, the topic that I would like to share with you today is about designing future, a forward-thinking approach by using the case that we have done in Thailand, future scenario of health and wellness in Thailand 2030. This is the collaborative research that my organization, public organization, work with the private sector and also other organization in the healthcare community as well. The title of the topic is about the designing future. But when we talk about the design, that from my experience is not about the creative design or product design, it's about policy design. And the policy design that we have done is try to design the policy that can handle with the uncertain future. So that's why quite important about us to recognize that the future of ours is quite have a lot of uncertainty. So that's why I would like to start my presentation with some of news that I came across maybe recently, this year and last year. For example, this one, the spike in dengue case due to the global warming warned by WHO. As you can see, we living in the uncertain world, so it means that something that we think was history, sometimes it's going to come back in the future. And also, first polar bear to die of bird flu, what are the implications? This news implies that something that we never experienced, something that we never expect it might happen in the future as well. So I think these two slides can define that how uncertain for the future that we need to experience and cope with. So I think many of you are already in the last, maybe in the last decade, you already experienced some kind of these two terms. The first one is the disruption, and another term is about transformation. This term is sometimes have been used, maybe interchange between these two terms, but I think the definition of these two terms is quite totally different. For the first one, disruption is like something like a major creating change. But for transformation is continuous process of change. So basically, I think for the people, we quite have some instinct or the nature of us is have some the resistance for change. So what we prefer rather than disruption, actually we quite prefer the transformative change rather than disruption. But how can we think about the transformative change that can happen in the future? Actually, there is the area of the technique or the area of study that we call the future thinking that introduce some kind of technique to use that's quite useful when you need to foresee something that might be not for sure, have high uncertainties. For example, in the past, in the traditional way, many people, when we think about future, we can have the big picture and comparing with the today, the present, and we try to set up the vision to achieve that big picture. We call this one is a strategic thinking, the way to achieve the big picture. But in the traditional way, we not include the future thinking into the way that we think about future. But for the foresight or for the next slide, please. Okay, it's come. For the foresight, we have an assumption that the future, the long picture, might totally different from the big picture. Something that you not expect, something that you never experienced before. So the today and the future view that we would like to achieve might be totally different. But what is the factor? What is the component? What is the driving force that create that long picture? Basically, we can grouping into main domain. The first one is about the change. Sometimes we call change is uncertainty. Sometimes we call change trends. And another dimension is about times. What is the time period that you expect for the future? So this is the way that we try to introduce or use the foresight in the way that we're looking for the future. But actually, I think many researchers or many of you already have an experience with the future thinking. The way that we use the term, for example, forecasting, forecast. I think many of researchers already try out something about forecast. For example, when you do like a statistic in the SPSS, you're running some static tests through the linear regression analysis. This is the way of forecasting. But for the forecasting, it means that you try to foresee the future based on the model, mathematical model that come from the data from the past to the present. So it means that for the forecast, the future is defined by the past. The information, experience, or any variable that you define in the past. But the foresight is totally different, but it's under the domain of future thinking as well. But the foresight, we try to identify some alternative future. The future that may not rely on the past. So for the foresight, the future is quite related to quite rely on imagination and opportunities. So for the foresight, the term future that we use the plural term for the future because we're looking for the option of the future. So foresight is for the foresight, future is something that unwritten yet. And future are a place for imagination and opportunity. So even in the area of policy making, design the policy, you can use the foresight to design the option of your future as well. When we talk about imagination, I would like to use this kind of example to show that how can we learn from imagination. I think, I'm not sure whether you have seen this movie before, The Contagion. This one is released in 2011, before the COVID. 2019. But if you already check it out, you can see that the contagion is about the spread of the pandemic, but different disease to the COVID. But the way that we handle, the way that government handle, the way that people handle with the situation is quite the same thing. But this one already defined the way to handle with the pandemic, maybe 10 years ago, before the COVID have been spread out. So this is the way that we can learn from the imagination from the people in maybe the Hollywood. They decide this the way to handle with the pandemics already. But the term that we use in our study, we call it strategic foresight. What is strategic foresight? Actually, it's the way that we use foresight to decide the strategy. Basically, for maybe if you're working in the business area, you may be very familiar with the strategy development, strategy design, and also you may be very familiar with risk management. But strategy design and risk management is a good way, good approach to handle with the big picture that you aim to achieve. But under the condition that you are already set it out, and maybe the condition that you think is not have a high uncertainty. But for the foresight, we try to introduce some new information to the way that you develop strategy. As you can see, the foresight, what is the output or the outcome of the foresight? Foresight is the process that you can get the data sets that reflecting the transformation of the future. But when you get that information, you can use all those information to develop strategy and also develop the plan for risk management to handle with that. But together, when three of them work together, as you can see, the overlap in the center is a transformation. So if you're working in some issue or some topic that you not expect transformation, you don't need to use foresight. You can use strategy design, you can use just risk management, because it's something that you're familiar and it's something that you not expect something that's going to be transformed. But if you expect that the transformation going to happen in the future, you may need foresight, because foresight can provide the data set that can reflect or foresee the picture of the future for you, and you can use that information to develop your strategy and risk management as well. Next slide, please. Basically, if you would like to use the foresight is a kind of like a research methodology as well. So the process is quite straightforward. The generic process of strategic foresight is basically comprised of 6 stages. But for this one, as mentioned, strategic foresight is the foresight technique that used for strategic development. So the 6 stages of the process can be grouping in two main blocks. The first one is a foresight process, and the second one is a strategic development. In my study that we work with our partner, we just done the first part, the foresight process, in order to build up the scenario to foresee what is the future going to be look like, and try to use this information, this scenario for the future to communicate with the policymaker in order to help them to develop the strategy for the healthcare as well. This is the case that we have done. We just released the report in the early of this year, but unfortunately the report is in Thai, available in Thai only. So I can pick up some page of some section of the report and share with you. The topic of the report is about the future of health and wellness. Oh, I'm gonna go back one slide first. For the foresight process, the most important thing, the first step is about the framing. You need to clear about your aim or your boundary of the research first. And then the second one, you need to do scanning the signal of change, scanning the data that can create change for transformation. And then in the end, for the foresight process, it's about the building. Try to develop all this change into something that have the factor or maybe the component that have the high impact to your future. And then try to illustrate what the future going to be look like. So for the foresight process, first one is the framing, second one is about scanning, and the last one, third one is about building the scenario. For the framing, when we start to run this kind of research, we found that for the healthcare system, it's quite very complicated system. So we use the two domain of knowledge area to be our framework. The first one is socio-ecology of the health behavior. is like an onion in the center. It have a layer. In the lowest level is about the individual level. It means that every factor that relate to individual level, like age, gender, gene, lifestyle, or personal wellness, it have the effect to the behavior of health of the people. And in the outer layer, it's gonna including like interpersonal aspect, organization aspect, community aspect, and also government and law policy aspect as well. And the small pink circle surrounding this one, we use the framework based on the healthcare ecosystem that include many components in the healthcare ecosystem, such as public health resort, health prevention promotion, and also including about food and pharmaceutical as well. So when we got the framework, we got the framing, our scope of the study already. Next slide, please. We need to start from exploring the context that we working under. Basically, when we try to collect information, this one is in Thai mainly. I don't have time to translate in English, but the main dimension, 6 main dimensions that we include in the context exploration is the first one is about demographic change. Because Thailand is in the aging society as well. The second one is about behavior and norm. The way that the lifestyle, the way that you consume food, the way that you're living have an effect to the health as well. The third one is about healthcare business. Hospital, insurance, all this business is related to the health as well. The fourth one is about living environment. Because, for example, in Thailand, we also have the problem with like air pollution as well that affect the health condition of Thai people as well. The fifth one is about public health system. And the last one is about medical healthcare and advancement. We try to identify the area that we need to concern and quite relate to the health system in Thailand. And this is the process that we have done in terms of the methodology that we done with the foresight. We can grouping in 4 main states in this slide. It have 4 main column, 4 main block. I'm very sure that you cannot see anything from this slide, just only the 4 block. But the first block is about signal of change. Actually, the research team have gone through around maybe 100 signal. We collect the signal from the place, from the research paper, from the publication, and correct them all, and try to prioritize based on the experience of the expert. We use the Delphi technique to invite all the experts to come and help us to prioritize the category of the signal of change. And then we also, the second step, we also explore some megatrends that happen across the world in order to analyze all this information together. And the third column is quite important, develop the driving force, because driving force is something that gonna have the influence to the future. In this slide, in our research, we develop driving force into 6 main driving force, and then we based on 6 main driving force, we develop 5 scenario in the end. This is the signal. This is some example of the signal. I'm gonna skip this one. This one is some example about the mega trend. As you can see, everything I think you have recognized already that is a mega trend in the area of healthcare system. But I'm gonna go to the next slide. Driving force. Driving force is the key milestone for science research. Driving force is developed based on the signal of change and also megatrend. From 100 signal of change and also megatrend, we try to clustering the signal that have related to each other and develop in 6 main driving force based on the Thailand context. The first one is the driving force is health actualization. Health actualization is another level of health awareness. Not just aware about the health, and also try to translate your awareness into the action as well. The second point is about the proactive public health system. It means that in order to create the good health ecosystem in the country, the government need to work hard and proactively to develop the public health system. The third one is about public health crisis and response. In the future, we expect that some public health crisis can emerge or can happen again. So we need to learn from the past, from our experience, and prepare ourselves for the future crisis. The first one is about healthy space and wellness design, because in order to do a treatment, we need to prevent. So we need the space that good design, have a good design for the health as well. The first one is about the healthcare advancement, the technology that you use to via telemedicine in order to help the healthcare system work efficiently and work properly. And the last one is the personalized healthcare, design the way of treatment to the people, to the characteristic of the people, to the attribute of the people, to the gene of the people. So this is the driving force that we have developed from the signal of change. And next one. From the driving force, we developed into the 5 main future scenarios. I'm going to show you 2 examples of the 5 future scenarios. Next slide, please. The first one is quite a scenario that quite pessimistic. We call it the dark of healthcare. We expect that in case that we cannot manage everything well, or in case that we do nothing with our healthcare system, the fragile health system being sensitive to either internal and external challenge. And also, we're going to lack of the supply and resource to the healthcare system. And the majority of citizens do not have access to adequate health service. And also, the number of the patients continue to increase rapidly. And mass resignation of the medical personnel due to the high workload and inconsistent compensation. And also the private sector, like a hospital and insurance, they're going to focus only serving the middle income group and above, someone that can pay for them. So this one is quite a pessimistic view. The next one, next slide. This one is the scenario 4, the dawn of wellness. It's quite more optimistic view compared to the first one. Thailand is the place that important on the health infrastructure, investing in the health infrastructure. And also, for example, the growth in the product and service that aim to people quality of life. So this one is another scenario. But basically for the policy maker, we cannot pick up just only one scenario and develop our policy to solve that scenario. But basically we need to integrate all these scenarios together. Because for some action or some intervene, we can use this intervention to encourage some good thing happen and also mitigate the bad thing to happen as well. So when we got this scenario, the most important thing is about the communication. Next slide, please. So for our research, for the research team, research is our role. But to turn the research to action, we believe that this is the critical success factor for create transformative change. The first one is about participatory process. All the research process that we have gone through, we try to integrate all the stakeholders, medical doctor, people, any private sector and community to join and to run the workshop together in order to develop the signal, develop the driving force, and also develop the scenario that they think is going to happen in the future. And then we finish the research. We need the communication space to the public as well, to the people, to the policymaker as well. So this is the 2 factors that we believe that is a critical success factor for creating transformative change. If you would like to create something that quite have an impact and can turn the future to the better future as well. The first one is participatory process, and the last one is about knowledge communication. And then after that is about the action. So that is some of my presentation that would like to share with you. And if you interest our report, you can scan to download. but you may need Google Translation to help for translation. Okay, thank you so much.
Our next speaker is Nikki Hardcastle, and she is coming from University of Technology, Sydney, where she is a Viscom lecturer, and she's also a design academic. Her research focuses on professional practice and industry engagement. So, welcome, Nikki.
Hi, everyone. Not long now before we have lunch. Hello, everyone. It's great to be here today. My name is Nikki Hardcastle, and I'm a visual communication designer and academic at the School of Design at the University of Technology in Sydney, Australia. I'm just going to see if the clicker works. Ah, it does. I'm really excited to be part of the Design for Change Symposium 2024. It's my first time here in Malaysia. And here as part of the program, and we've brought our first students across over to be part of the study tour. I'm really looking forward to working with both students and the academics as we immerse ourselves in the world of health and sustainability and move forward with our briefs next week. Oh, that's me at UTS. So today, as the title suggests, I'm going to talk about the work we do at UTS, specifically in relation to curriculum. That includes designing campaigns, I'm going to put my glasses on, and the strategies used to create them. At UTS, I'm privileged to coordinate 2 initiatives within the visual communication undergraduate degree. So the first is socially responsive design, a subject that allows students to work as real-life, socially engaged designers with real-life clients from the community. They apply design thinking and strategies to solve organisational problems and enhance the impact of these organisations. This collaboration shows students how to step outside of the university and into the community, building practical skills and working on real-life issues. And the second is the D&AD New Blood Awards programme, which I brought over from the UK. This competition is one of the largest of its kind for emerging creators, providing an opportunity for students to showcase their talents through briefs set in partnership with some of the world's leading brands. It's kind of like the Oscars in the design world. That's how I like to think of it. So what I'm going to do today, I'm going to share 3 campaigns developed in these programs and discuss the strategies used. So some of them are not specifically related to health, but I think the strategies used might help you as we move forward. So what is a campaign? A campaign is a coordinated effort to promote a product or a service or a cause. It typically consists of a series of activities designed to reach a specific goal. It involves clear objectives, strategic messaging, and understanding the target audience to ensure maximum impact. Overall, campaigns leverage the power of information, education, and emotional connection to drive meaningful and positive change in behaviour, attitudes, and societal conditions. So they're used to inform, educate, share ideas, change behaviours, shift attitudes, and drive positive change. Oh, okay. I'm going to share some key strategies. Oh no, Debbie Millman, that's right. So as Debbie Millman said, design matters. It can change how we think about the world, how we interact with it, ultimately leading to shifts in behaviour and culture. So I'm going to share some key strategies from the teaching team that we've developed through both programs, through Social Responsive Design and the D&AD Studio, focusing on 5 components of successful behaviour change campaigns. So the first is to generate momentum. It's important to cultivate momentum around an issue and a sense of energy and importance. You need to get your audience on board pretty quickly to give the campaign context. A simple idea. Unlocking a simple, memorable core idea that stays with people. Distill your thinking down to what I like to call a single-minded idea. Too many times I've seen overcomplicated messaging that gets lost and it doesn't connect to the audience. It has to be memorable and will stay at the front of people's minds. Aim to be direct first and clever second. So many people I've seen over my course of teaching tend to overthink situations and want to put everything into a campaign. It's really good to kind of distill those thoughts and be really simple and be clear. Avoid the temptation to cover too many angles. Engage inclusively. Engage audiences with an inclusive tone that speaks with the audience, not at them. Think about the language you use. Have empathy with the target audience, listening to them to understand what they think and how they behave, making sure your campaign is aligned with their values. It's important to tailor the message and the creative content specifically to your audience and demographic. And positive benefits. Emphasising positive benefits of the behaviour change to foster collective buy-in, highlighting the positive consequences of behaviour change is often more motivating than focusing on the negative. People are more inclined to act if they perceive clear benefits for themselves and their communities. And action-oriented is the last one. I could probably do quite a few points, but I just wanted to keep it down to 5 for today. You know, spell it out. What can we do and what can we achieve together? So to illustrate these strategies, I'm going to share 3 case studies, all designed by students, not professionals. They're all done in an undergraduate degree. The first is Blackout, the second Say My Name, and the third is going to be Flip. So the first project I want to talk through is called Blackout. And this was done in the D&AD studio. And in response to a brief set by Connect for Climate, students were challenged to design a campaign that advertises the power of a sustainable lifestyle. The aim was to help young people find the most impactful actions within their local context and countries that can create meaningful change, driving them to action, and provide a way to track the difference that they and everyone else involved were making. It was 2020, and in Australia, we were experiencing some of the country's worst bushfires on record. The problems the students unearthed through their research was that Australians felt helpless while their country burned, and the bushfires had produced over 250 million tonnes of carbon emissions. They designed a carbon-neutral app that changed the settings of mobile phones and tracked digital habits to help produce as few carbon emissions as possible. So I'd like to introduce the Blackout campaign.
Young Australians are watching their country burn. 1 billion animals are dead. 250 million tonnes of CO2 produced. We feel totally powerless. As we hopelessly watch, scroll and share videos of the bushfires, we think, I'm just one person, what difference could I possibly make? What we don't realise is that the problem is in our hands. For every 1 gigabyte of data used, 27 kilos of CO2 is put into our atmosphere. That's more than a flight from Sydney to Melbourne. So what do? We propose a blackout. Connect for Climate's carbon neutral app changes the settings of your phone to produce as few carbon emissions as possible. By tracking your data usage, you can create a sustainable digital lifestyle. Once you're set up, you don't have to do a thing. We'll switch your default video preferences from high definition to standard definition. Save 20 kilos of CO2. We'll let you know which apps have a poor CO2 rating and provide you with better alternatives. To help you stick to your new habits, you can even set a daily data allowance. Once you've reached the limit, we'll black out your phone. Blackout will send you 1 notification a day to show you how much data you've saved. We donate this data to Australians in need. Our partners will grayscale their logos and hashtag blackout on socials. We're showing young Australians the real impact of using their phones. We've teamed up with Google Maps to track how your little changes are making a big impact. Blackout will alter everyday user behaviour without you having to do anything differently. You can make your actions count with Blackout.
So the Blackout campaign, it fosters a sense of immediacy and urgency. The campaign sets the scene for urgent action, and the images of the bushfires and the current news and the statistics, the urgency is crucial in motivating the audience to engage immediately. The call to action, make your actions count with Blackout, is really simply stated. The campaign shares examples of everyday actions and how much carbon they produce. By providing clear instructions, the campaign ensures that people know exactly how they can contribute with tangible results. The data visualizations emphasize the measurable impact of individual and collective actions, and showing these concrete outcomes helps to validate the efforts of participants and encourages continued involvement. So the next campaign I want to talk to you about, next slide. I didn't do enough clicks. Oh, there we go. Is Say My Name campaign. So Say My Name is a UTS Multicultural Women's Network initiative that aims to increase awareness and educate the UTS community on the importance of saying a name that they have not said before. The students' response was to create a friendly, playful campaign that celebrates diversity, making the experience of saying people's names easier than they think. Through sharing these stories, they're able to give a voice to the diverse community of UTS and engage them in starting conversations. This was supported by a suite of educational tools, pronunciation guides, workshops, and visual and digital media assets for use on campus. I present Say My Name.
Oh my god, hundreds of thousands of times. I can't count how many times this has happened.
Usually the Maylene gets mispronounced. Not even just sometimes, but probably 90% of the time that I introduce myself when people see it
written down, and before they even ask how to pronounce it, they'll say, oh, where's that from? And they immediately try and
say like Nikki Fortis, or they'll just say Nikki and then like trail off and not bother to finish it.
It's pretty common, as well as misspelling. I'm just gonna call you Cece. Just whatever, it's okay.
And so I'd get called Benedict or something like that.
Mostly Jemima, Jemina, Gemini.
It sounds like Japanese, so like teriyaki, orangutan or something. So
it's something that I've gotten used to, but it's something that is annoying. It's very annoying. I don't like it.
What does your name mean to you?
I guess it's, it's about
my connection to my culture. I don't think I would have such a strong relation to my Cambodian heritage if I had a different name.
It's about my ancestors and my family.
I was named after my grandfather because he was nicknamed that because he was the chief of the island.
What my name means is
pure-hearted,
wisdom, listener,
light,
delicate white flowers.
So Hananime Saram, Haram, man of God.
Bear, like the animal.
What is your name?
Name is Ruben Savariego.
Yeah, and Nikki Faridas.
Haram Wu. Daniel Taramaki Rangura.
Name is Mohammed Nuruddin Al-Hamouri.
Amanda was Maylene.
My name is Elaine Marie Carbonell Laforteza.
Kumudika De Silva. Satiri Tak.
Both of which always get mispronounced, but...
I taught a lot of those students as well. It's so nice to see them again on the big screen. So, the students... so it's a campaign should converse with its audience rather than dictate to them. It's the inclusive tone invites participation and creates a sense of belonging. Language is super important. The how-to guides use clear language to advise students and staff on what not to say and what they could say, with a prompt to remember to be respectful, to listen, and that practice makes perfect. There's advice on how you can correct someone on how to pronounce your name, with scenarios on what to do when you first meet someone and also when you already know them. An additional email signature guide allows staff and students to create their own audio recording, upload it to their email signature, along with the phonetic spelling of the name and a link to the audio pronunciation in the signature. As Ryan Curtis, studio leader, said, you know, names are not just words, they carry our identity, culture and history. Pronouncing them correctly in a small act of respect, that has a significant impact. So the third and final case study that I just want to run through is called Flip. And this was through the D&AD studio. It's in a response to a brief set by Penguin Books, and the Flip campaign aimed to encourage Gen Z to engage with reading more books and specifically to design a suite of merchandise. The team's main insight from their research was clear. Gen Z doesn't want more stuff. They want experiences. They want membership perks and community-focused initiatives. They didn't want another tote bag. They wanted to do good. So the problem was set, how can we challenge the traditional definition of merch to help Penguin build fandom amongst Gen Z readers? The team in their response literally flipped merchandise on its head and reimagined the simple book swap to build community.
Gen Z doesn't want more stuff. 67% of Gen Z believe that brands must be sustainable. So in the age of fast fashion and even faster fads, we think it's time to ditch the tote bags and the mugs for products with more purpose. At Penguin, we're rethinking merch and flipping buy more to read more with Flip. We've reimagined the humble book swap to build community around the books you love. Head online or visit your nearest bookstore to choose a book. And just like that, you've joined the huddle. Get connected with your Penguin Pass to access the Flip community and start swapping. Your first book comes in one of our FSC certified book boxes, so you know you're doing good while giving. Inside, you'll find a recyclable instruction manual turned bookmark set so that you can read in style. Once you've read it, tell us what you think and send it. As a member, you can look forward to receiving a new pre-loved book each month. Jump on the Flip app and start engaging with the global community. As you rack up reads, the app will profile which books you vibe with the most so that we can get to know you. We'll catalogue each book by title so you can see what others had to say. Explore the map view and see just how far the books you read have travelled. But be warned, spoilers are ahead. We'll get into the ins and outs of what moves you and what you love about the books you've read and the ones you might find at your doorstep next. You can unbox your reads using #PenguinFlipIt on BookTok. We're even partnering with your favourite bookfluencers to get more people reading for good. Want to get together offline? We've got you. With each swap, your Penguin Pass gains you access to community events in your area. Flip is merch made for a generation that loves to share and reshare. It's a space to share your passions, build community, and put your best flipper forward. Let's make merch meaningful and change how we read for good. Let's flip it.
So successful campaigns hinge on a clear, simple idea that remains memorable. The Flip campaign centres on a straightforward idea of swapping books encapsulated in the action of flipping. They didn't reinvent the wheel. You know, the simplicity of the idea, exchanging one book for another, transcends language and cultural barriers, making it accessible to a wide audience and having universal appeal. Again, note the language used. I really loved it when they were rating the books and they said, you know, the book was a flip or the book was a flop. That was kind of one of my favourite moments in there. And the fact that the team literally flipped the brief on its head by not producing merchandise, I thought that was really clever. So it focuses on the positive outcomes of participating in the book swap, gaining access to new and exciting reads, fostering a sense of community, and promoting sustainable practices through sharing. By emphasising these positive consequences, the campaign motivates individuals to participate, seeing clear, tangible benefits for themselves and for others. The audience, knowing that their small action contributes to a greater good, can be a powerful motivator. So by making the positive outcomes clear and immediate, the campaign encourages repeated engagement. People who experience the benefits of the book swap are more likely to continue participating and even advocate for it within their social circles, leading to a sustainable change in behaviour. And you can see some from the quotes from DNA. You know, that's what they picked out about the campaign. It was really simple and clear. Yep, I'll let you read them. So in summary, I'm just going to wrap up quickly. I'm just aware of time. Designing a campaign that effectively changes behaviour requires strategic planning. You've got to generate momentum, keep it a simple idea, engage inclusively, talk about the positive benefits and make sure it's action orientated. You want people to act now. By incorporating these principles, we can craft impactful campaigns that inspire real and lasting change. And I hope the strategies I've shared today help the students in the room all move forward when approaching. Thank you very much.
All right, and our last speaker for this session is Jae-Hong Liu, who is the head of international development at the Nanyang Polytechnic School of Design and Media, where she has been for 20 years, a long time, very long time, leading lots of different design programs. So she's going to talk today about her approach. Come up, Jae-Hong.
Afternoon. I'm happy to share here today in a different perspective. So I'm a trained architect. So I'm teaching design, architecture, and of course I conduct different workshops, use design thinking, service design framework. So today I'm going to cover the different framework under sustainable healthcare design. Okay, so when we're talking about sustainable in healthcare, are we talking about reduce less waste and save energy? But definitely it's more than that. So if we define the healthcare design, we can actually separate them into 4 different pillars: environmental, economic, social, and system. Yeah, I'm going to share more about that. Okay, firstly, environmental sustainability. So, because nowadays when we're designing hospital, it actually involves a lot of different elements. So when the inbuilt environment, when you design the hospital, healthcare facility, it actually involves the community. So the design need to be compact and efficient. Okay, so when we design a facility, it's ethical, responsible for the project team to consider a few areas. So, of course, we need to minimize the energy use, use passive design, and increase ventilation. So in Singapore and Malaysia, such a tropical country, yeah, passive design is important. It's meaning you could use architectural elements such as a bigger roof and overhang to provide more shading in order to reduce energy use. Of course, we are encouraged to use natural and ventilation instead of aircon. And another point is we should apply biophilia design to improve the biodiversity and the environment. So it actually also contributes to the passive design and also increase the well-being. So nowadays we're talking about more green building and more trees inside the building. So if you come to Singapore, the Changi Jewel is a typical biophilia design. So it uses a lot of trees, bring people closer to the nature. Last point is we should source renewable building material to lessen the manufacturing carbon footprint. Okay, so I'm going to use an example in Singapore to share with you these concepts. Okay, so this is a hospital, Singapore built about 10 years ago. So this hospital won many green awards, local and internationally. Why is it so special? So before 2010, so a lot of hospitals in Singapore, they just focus in treating the illness. But when we are getting better in economic development, we tend to focus more in well-being rather than just illness. So of course, with the aging population, we need to build more hospital and healthcare facilities. So when the architect team come out to design this new hospital, so they want to make it a hospital in a garden. Yeah, so it happened, the site, there is a pond outside the hospital, so naturally they want to bring the pond and nature in the hospital itself. Okay, so if you look at the original design, so extend the pond, so they built a garden. So surrounding the garden, it connect all the clinic, the specialist clinic, the ward, and the public facility together. So it not only benefit the patients and the staff in the hospital, it also benefit the people nearby. Yeah, so today you see the garden is actually become a community area for different people communicate and enjoy the place. Yeah. Not only the garden in the ground floor, they also built a rooftop garden and a farm for the staff and community nearby to use it. Surprised, they're actually building the garden on top of the operating theater. In the past, it may be crazy, but they actually make it, and the users actually enjoy using the spaces. So more photos about the garden. Yeah, so the last point I shared just now is about the renewable material. So on the rooftop of the hospital today, they also use the solar panel. And of course, they use a lot of prefabrication technology, so to save the manpower and save the carbon emission. Okay, so the second pillar is more important, is social sustainability. Like I mentioned just now, the hospital is more than a single building. It actually connects people together. Under this point, we have a few strategy. So of course, it's encouraged to have a center space to connect people together. So, and also focus providing more important hospital department, focus and treat the people, yeah, and accelerate patient recovering rate. So I also talked to the hospital staff. They actually have an innovation team. So in order to help the patients cure and stop coming back to the hospital, because they share, this hospital actually have about 800 beds. So if the patient, some of the patients actually keep coming back, so they just discharge. After a few weeks, they come back again because the same problem, they fell down again. So the hospital team, they actually went to check the home of the patients, so they can help to actually improve the home environment. After such action, so the patient stop coming back so frequently. Yeah. So last point is the decentralized of facility. So instead of everyone coming to the hospital, so they decentralize the patients to different facilities around the island. Okay, so this is the floor plan showing the hospital. So the hospital is in red, so you can notice next to the hospital, there are the pond, the Safra Club is for the Army and the National Service guys. So, and also there is a community hospital and clinic. So with all this, it will address the social sustainable issues. And next slide, with all the initiative, it actually brings people together. So hospital will conduct courses for community, then community and come to perform, use the hospital's public space, and they also come to use the rooftop farm together. Yeah, so next, it will be economic sustainability. So there is, someone say when there is, does not translate to economic value, sustainable won't last. So the hospital design should address the strategy for the most hospitals' construction efficiency and the subsequent operation costs. So in order to do this, the team or innovation team of the hospital should constantly look at the process. Yeah. So in order to do so, the construction process will be important. So just now some of speakers talking about pandemic. So pandemic also hit Singapore a lot. So in construction sector, so in the past we rely on a lot of foreign workers, right? So during the pandemic, we actually cut down the foreign worker. So we realized in the construction sector, we can't continue to do that. So when doing the design process, so we have to address the construction process. So by having more precast parts, so the precast parts can be manufactured somewhere else. So in the end, come to the construction site, they just assemble them together. By doing so, can reduce reliance on the foreign manpowers and also support local employment. And second point is to reduce operational costs through the renewable energy and minimize waste. So rooftop solar panel and natural ventilation will help to address this. Lastly is the hospital or healthcare facility should continue improve the services model and make it more efficient. So at our school, we actually work closely with healthcare facilities. And this year, we just signed a MOU with IHH, one of the biggest healthcare facilities in Singapore. They are private, so they have 80 hospitals all over the world. So we actually train their staff by invite them to join the service design courses so they can learn the thinking process, then they go back and review their processes. Yeah. And this is a typical prefabrication building. If you can look at it carefully, a lot of walls and ceilings, they are actually prefab somewhere else. So this building actually won an award in terms of structural sustainability. Yeah. And this is a solar panel. So if you come to Singapore next week, you will notice a lot of residential, they have a solar panel on the rooftop. Actually, 80% of rooftop being covered. Of course, hospital also do the same. So this can substitute some of the energy used in the hospital. So last slide, this is actually about the integrated care model in Singapore. Not sure how this is happening in Australia, but in Singapore, in order to reduce people coming to the hospital, so they actually have different levels of care. So primary, initially people will go to clinics, either public clinic or private clinic. So for minor illness, flu, minor injury, they can settle in the clinic near their home. So when there is more serious disease, then they will go to hospital and go to integrated care. Or if it's long-term illness, it will be a long-term care, and there will be hospice for end-of-life care. So this is how Singapore deal with the different kind of need for the care system. Okay, last point is system sustainability. I think this part we can do a lot on it. So everyone can contribute and review the different requirement in the care level. So review the system, make it more efficiency, and offer better experience and other values for patients and even staff and family members in the hospital. Okay. So if we analyze it, actually there are 4 levels of system in the hospital. So it includes patient, the care provider, staff, and organization. So if you go and review every touch point of this system, you can find a lot of area to reduce. So doing this, you can actually not just address the patient's welfare, you can also address the staff welfare, because in Singapore, in the care facilities, staff retention is also a problem. So if improve the processes, make the nurses and healthcare staff their work easier, then they will willing to stay and they are happier and give a better experience to the patients. Of course, we have to use technology to do this. So we can use design and service design thinking process and address all this, improve the procedures. And lastly, we can redesign the system to help to improve the facility in individual and the system level. Okay, so this is a framework, a roadmap showing different layers in the system. So of course, it's a big picture. So when coming to design, we can pick one of the part to analyze the user needs and address the different pain points. Okay, so I'm showing a few more examples. So some of the problem we always facing in hospital is the wayfinding. So this is a part of the system design. So designer can help on this. Yeah, and next one is accessible design. So different hospital would have different methods to address this, from parking to toilet to different part in the hospital. So this is more example showing the accessible design in the hospital. And not just that, and other facilities to help to make it more convenient in the hospital, it can be addressed as well. Yeah. So similar to like we visit the cancer center, they have a sustainable corner. So So hospital is not just for treatment. It can also used to have a campaign to promote healthcare. Okay, and this is one of the project our student work with a company. This is a typical system design to promote sustainability. So thanks to technology, nowadays we can actually simulate the energy used in a building. So this is a digital model our student built together with a company. So with the digital model, you can actually simulate the energy use in different part of the building. So you can identify the high energy use unit, then you can do something about it. So this is just an example. So many more can be done. Okay, so in conclusion, the sustainable model and the framework, it can help to refine our understanding in hospital, in healthcare facility, and so we can think from these 4 different areas to find out solutions and help us to have a better healthcare environment and promote sustainability. And last few slides, I'm just want to share a few case studies. This is the just now the slide I used, the Khoo Hospital. It's the first hospital to bring greenery and make it a more lively community. Other than just treatment, it will provide, address the wellness of everybody. And after that, okay, the video is actually working.
Khoo Teck Puat Hospital is one of 8 acute care hospitals in Singapore. It is predicated on the idea of a healing environment, which links the well-being of its occupants to the physical attributes of the building. The heart of the hospital is an open-to-sky court filled with dense green cover. What differentiates this from others is its generosity and openness. The water systems connect to wider hydrological systems in the catchment. The green spaces inside the court are linked to greenery in the neighborhood, creating a hotspot that attracts birds from nearby nature reserves. The public spaces of the hospital have become a social hub for the neighborhood. In a recent study, some 15% of all who were surveyed on hospital grounds said they had come for social and recreational reasons. Volunteers, mostly retirees from the neighborhood, tend to rooftop farms, and the food grown here is sold at weekend markets. Since it opened in 2010, the hospital has altered the urban and natural ecosystems around it. There are new pathways for pedestrians, new biophilic spaces for relaxation, new lines of movement for birds and butterflies.
That was 2010. So we will see after 10 years, what are the new idea in the new hospital design. So this is Sengkang Hospital. Khoo Teck Puat Hospital is at the north side. Sengkang Hospital is in northeast. So actually Singapore is building more and more hospital. So we take a look at the Sengkang Hospital. How to play the video? It's fine. If there is opportunity,
Sengkang Hospital is a healthcare campus designed and planned for sustainability in 4 areas: environmental conservation, health and wellness, social inclusivity, and community building.
The campus is organized and laid out to achieve good aspect of orientation, good distancing between buildings, good functional adjacencies, and good flow for a greener and cleaner environment.
The architectural and urban design of the campus was envisioned with biophilic qualities. Green roofs that double as pocket gardens seamlessly integrate and connect people with nature. To encourage social inclusivity and communal bonding, spaces are designed for flexibility to accommodate different activities and functions. Advocating sustainability and building resilience, Sengkang Hospital campus has become a community heart for residents in the neighborhood.
So the last one, I have no video, but I just want to show you something very special. If you notice this building, the facade, it have those curve feature. So it actually not just for aesthetic, it's actually provide more airflow. So the room is cooler. So on top of that, yeah, the patient is actually, every patient has a window view. Sorry. Every patient has a window view. And also outside the window, there is greenery. Yeah. Through the orientation of the design, they actually also reduce the demand for light energy. And they also, of course, use a solar treatment system to provide 100% of the hot water supply for the hospital use. And they also use energy-efficient aircon chiller and many more design consideration. That's why this building actually won the Green Mark Award, Platinum. There is only one Platinum Award every year. So, so you can realize design is not just for aesthetic anymore. So using design element actually can help to promote sustainability, help to have a more effective built environment, yeah, for the users. Yeah, that's what I want to share. Yeah, thank you very much.
Thank you for those amazing speeches. And now I want to invite the speakers to come back up so we can do a little bit of a Q&A before lunch. So can I get Jae-Hong get back up here, please, and Ibn Paki, as well as Nikki, and Leo will lead the Q&A.
We're almost there, so we're going to go for lunch after this session. Whoever asked the first question, get the first lunch. All right, thank you so much, esteemed speakers. I'm just going to, without further ado, open the floor for questions. We start with the students. I have one volunteer. I think she wants the first lunch. I'm kidding. Go for it.
Hi, my name is Marin. I'm a nursing student from Nanyang Polytechnic, and I really like the sharing by Dr. Paki. So my question is directed to you. So I'm just curious, right, with the human imagination being infinite, during the process of coming up with scenarios, are there any aspects that you consider, like boundaries or guidelines, to ensure that the foresighting is realistic?
Actually, I think I have 2 points to answer your question. The first one, for the process, I think the first step about the framing is quite important. When you start the foresight research, you need to have the clear vision or maybe clear objective and clear framework. That's why in my research, I start with the research framework, try to include all the aspects that quite relate or have an impact to the health health system. That's first point. So as a researcher or the research team, you need to work together in order to set up the framework first, and then try to agree with the clear boundary of the research framework. And for that research framework, you need to try to open your mind in order to include different dimensions that sometimes is not in the area of your expertise into that framework as well. That is the first point. The second point, when you already have the clear research framework already, but during the process of for example, the participatory process, I think that is the quite important roles for the facilitator, the one that who help to conduct the activity with the key informant, key stakeholder to join in the process as well. The first rule for the facilitator, you need to try to let them share and don't try to press any pressure or any frame to them. And then try to collect all the information based on your framework that you communicate with them. And then after that, it's going to be the role of the research team to collect all information and try to set the priorities of all information that you got. So in terms of the process, I think that's 2 points is quite important thing in order to let people or the stakeholder to come join and try to express their imagination to your research project. Yeah.
Thank you so much for a really spot-on question. This question is a quite common question in design thinking and design framing, and it always reminds me of this famous quote from Einstein that it says, if I had 1 hour to solve a problem, I would spend 55 minutes defining and refining the problem and 5 minutes solving. I think with that we can lead to the second question from audience. Second question? Yes, please.
Hello, I'm Manu and I'm from QT, from Australia. So my question was based to the speakers from Thailand. In one of your presentations, well, both of yours, you kind of mentioned how behavior and norm sort of plays into like how healthcare systems are like adopted. And obviously there's like an aging population in Thailand, and as we're like pursuing innovation in these systems, like often with digitalization, everything, the demographic can't really easily adapt. And also like the design considerations, like from a Viscom standpoint, what we, the new generation, is used to, like more clean, minimalist design, they often don't really think it might look official or just aren't used to that sort of layout. So what are like some challenges and like some perspective that you have on it?
Who is that question for?
It's kind of like a mixed question, so if any of you can answer.
Then we're going to pass the mic around. Pokey, maybe you start with you since you have the mic.
I think for the big share, I think for Thailand, we're quite lucky that we have many good doctors and very good, infrastructure for the healthcare system. As you can, during the COVID, it could be said that our country can cope with the situation quite well. But what we concern is about the future, because I think we cannot separate the issue about health to the issue about economic and lifestyle as well. The first point, I think the big challenge, the first one, we in the aging society, it means that we're going to have maybe the people that need to rely on the healthcare system and cannot generate money. So how can we, the second point is going to be how to finance the health system. So the good thing is we need to prevent rather than do the treatment. So I think everything is come to the same final question: how to prevent, how to make the people to learn about prevent their health rather than get sick and go to the hospital. So that one is quite a big challenge to achieve the same aim goal: prevention rather than treatment. Yeah.
So thank you for the questions. It's really a great questions to ask. Like speaking from my first-hand experience, like the challenge that related to like healthcare design can be coming from like all the designers want to digitize all the healthcare informations and everything like that. So not all the design solutions or all the answers can be answered by just digitize everything. Like there's digitizations and digital transformation, but it will be valuable when it's ready and it's appropriate for the users. So I believe like whether you guys love like a minimal design, but it's gonna come to the answers where is it meets the user needs, or is it like is it user involved? Like it can be minimal and it can be aging friendly also. And speaking about the budgets, within the limitations of the design in our country may have, we can allocate so many projects within like a minimum budget, and it can go digitized or without digitizing. And from my personal experience, I believe like the digital app or the digital technology is a valuable tool in this era. But on the other hand, like in-person experience or the physical artifacts can be equally valuable as well. Yeah.
Nicola or Jaehang, do you want to add to the answer, or should we proceed with the? Okay. I would love to have one more question from audience. Do we have question among audience? If not, I'm going to go ahead with my question, and this is to all of you. Sorry, I missed that.
Sorry, so I guess my question, my name is Wing Pang and I'm from the University of Technology, Sydney in Australia. And my question is about how we can design social experiences or systems that are physical in nature, that can facilitate people who might have accessible needs. So for example, I've heard across the different talks that some elderly people might have accessibility issues when trying to get to the hospital or trying to get involved with a healthcare community. And I know that the Singaporean health program at the moment is trying to do prevention of diseases through community engagement. So in terms of like a design perspective, how can we involve people who might not have those?
Yeah. If I understood correctly, I think it's about including the stakeholder in this particular scenario, elderly, and like how they can have a voice in this process and decision making. Am I right? Yeah. You can start.
Actually,
yes,
Singapore government, other than the clinic, they also have community care. So, for example, if you have elderly at home, so you need to work, you can actually send them to those daycare center, and also under the People's Association, it's a government sector, not a government body, so it's like support the community. So they actually have many aging program. So they provide a gathering program. They also have facilities in almost every residential area. So they have program to gather them together. So of course they have community run by the young people, but they also have community run by the elderly. That means they have their own community, so they have dialogue session with the people association, so they can have the feedback, to the government indirectly. Yeah, but they do have channels. Yeah.
To answer your questions, I would like to clarify in 2 points. So the first point in Thailand case study. So in each city in Thailand, they will have like a city hall where the officers create like young at heart programs, try to encourage an older adult to feel confidence that they can do more stuff after their retirement life. And that would be like we can engage them and collect the data from those community that volunteer to be in like a healthcare design projects. And on the following point that I would like to suggest is the tools to encourage them to be participants and give the insights is also important. If they're not familiar with the digital tools, so maybe suggest them to use like an artifact tools like cultural probes. Many of you might have heard of it before, and it can be fun and they can do in their own times, and that will give you an insight in their own environments, and they will get familiar with the things that they've done in everyday life, like writing diaries, taking photos, and those kind of nostalgic activities that they can bring to the table for you. So that's hope to answer your questions.
Yes, for this question, because I'm not in the area of designer, but I would like to add the 2 points to your question, because I think for the healthcare system or healthcare issue, it's quite a complicated issue. So the first point, when we would like to develop some solution, it cannot be run in only one way. I think the top down and the bottom up have to run together. Top down, sometimes you need the policy, the solution from the government who can looking into the future and decide the direction of the city, of the town, of the system, or of the country, and deploy some policy across the country. And also from the other point of view, you need the bottom up as well. You need community, you need people to join and identify their need to the system as well and develop solution for them. That is the first point. Top down and bottom up is need to go along together. The second point is about many designers have a good idea, good initiative for designing the solution, but how to run in the sustainable way, because all the project, all the program, all the campaign need money to run. So I think for the designer or maybe the solution provider, they need to think about how to design the business model to run as well. One of the business model that in Thailand we use in many projects that quite relate to the health system. We running based on like a social entrepreneur, social innovation, social enterprise. They not aim to make the money, they not aim to get rich, but they aim to get the money to earn their platform, to help their platform to run. No need to rely on just only donation or free money for the government. They can rely on the money from the community or from the service itself and can run in the sustainable way in the long run. Yeah.
Thank you. Nikki, do you want to add anything to the question?
I think just from a designer's point of view as well, it's really important to kind of immerse yourself into the area that you're working in, I think, and work alongside people. And then, and also be, I've lost my train of thought now, but be really clear about what you're doing. It's not really about, and think about the simplicity of the idea. And I think someone earlier said it's not about how it looks, it's about the idea and how you can convey that. So simplicity and then working alongside people is a much better way to start off, I think, from a designer's perspective.
Absolutely. With that said, definitely you guys as a young future designer and health practitioner gonna get a really great opportunity and chance to practice and experience this firsthand by tackling the problems next week with your project in the study tour. I'm not going to delay the lunch break. I just want to use this opportunity one more time to thank our esteemed speaker and the questions from the audience. Thank you so much.
Okay, everybody, now the long-awaited lunch. And we will have the lunch upstairs where when we started the symposium today you were, so just directly upstairs. We'll lengthen the lunch a little bit because we've had a bit of tech issues that blown out the time. So we'll come back here at 2:25. Okay, so come back in at 2:25. We have a really exciting program for the rest of the day going through really interesting case studies. So come back 2:25. See you soon. Enjoy lunch.
Test 1, 2. Okay.
Industrial design as well. So come on up, Daphne.
Woo-woo, fan club, woohoo! So you've all just had lunch, and so all of your blood has gone into your stomach and your brain's suffering a bit now. So I want you all to just get up, stand up, stand up, everyone. Stand up. I wanted to get some nutbush happening, but it could be dangerous. But what we're going to do now is stand up, everyone. And arms in the air, like you just don't care. Wiggle your hips. Wonderful. Few claps. Whoa, 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 whoa. Down by your side, shake it all about. Shake your shoulders, shake your head, shake everything, and stomp. Bit of a stomp. All right, that's it. That's my presentation. Love you, bye. Oh dear. All right, so righty-ho. I'm going to get on with this. Lovely to be here. I've really enjoyed this morning's, all the presentations this morning. I have to say, every one of them, I thought, oh, that's really something new, which was wonderful. And this is what these things are about. So the calibre of the presentation this morning was fantastic. Ooh, that's me. All right, so I'm here to talk about sustainability in healthcare. You've heard a lot of definitions about that, so you've probably got quite a lot already happening. But I thought I'd just start by just saying, situate myself. So, as you know, I'm at least to explain, director of the Design Health Collab, and we're a group of design researchers and practitioners that are applying design research to, complex healthcare challenges to create impact in the world. And our projects are either in the world or on the way there, and some of them, it might take a little while and they might not go there at all, but we learn from them and it's all great stuff. We collaborate with clinicians, healthcare organisations, university researchers and other universities. And we also see as part of our responsibility is nurturing the future health design nurse or even health design practitioners like healthcare workers who are interested in using innovation and design to solve the many problems. Well, what's a problem? It's many challenges that we have in healthcare, and we know from our research that it's often the clinicians that are working in hospitals on the front line that are trying to solve their problems. And we work with one guy, because I'm so casual, one professor, Don Campbell, who's the Chief Medical Officer of Northern Health now, and he just says, you know what, the healthcare situation is so diabolically in trouble that we really need designers to come in and help us rethink it. So we're here to talk about sustainability, and this is a beautiful utopian image of what we would like to see healthcare become. So we have this wonderful system taking care of people wherever they are in the world, taking care of their experiences, but also living in harmony or placed in harmony in the natural world. So this is what we would all like to see. So healthcare that treads softly on the environment. So one of the things we're doing at Monash University is trying to think about the future of healthcare. And I was really inspired with the talks from this morning from our colleague from Thailand, who was talking about thinking about, the future in terms of, what could be possible, thinking about scenarios and feeding them back. So we're thinking about the future of healthcare in an interdisciplinary way across the university and with our partners, because every time we've done all these projects in the past years, we always come across the same challenges. There's systemic issues around healthcare that everyone keeps on bumping their head against. So why can't we all come together, all the different disciplines, and work together to solve or create a vision, not a vision, but a preferred future healthcare scenario that we can all work towards. And these are the 5 kind of areas we're thinking about healthcare through. So these are kind of 5 lenses. And one of them, as you can see, we've talked about workforce being an issue. We know that there are a shortage of 5 million nurses worldwide. There's a shortage of 100,000 nurses in Australia. It's really chronic. And we can never train enough nurses to fill those roles. So we have to think about, how do we deliver healthcare in the future? And the environment plays a big role. So we've been working towards now this idea about distributed healthcare, and we can see in Singapore that they're already talking about integrated healthcare across the community. So what we're imagining together with our healthcare partners in Victoria, so I'm talking about a small part of Australia, it's kind of small, there's 6 million people, it's kind of big as well, maybe the size of Singapore, is at the moment we've got a hospital that delivers all the clinical care as well as acute care. So what if in the future, rather than having, hospital in the home, does everyone know about hospital in the home? Yes, of course, the nurses are nodding, because our hospitals have got such a shortage of beds that they're also now, as soon as they can, moving people back into the home and taking care and monitoring them at home. So imagine a future where rather than 150 beds that Monash Health has, as the largest healthcare provider in Southeast Asia, has 150 beds that they call HIF beds. Imagine if there's 1 million of them. So most patients are getting cared for in the home and not necessarily in the home, because the home is not a safe place for everyone. So imagine a community that's set up, maybe like Putrajaya. So if you think about Putrajaya, we set the community up with healthcare delivery in different ways, and maybe healthcare workers that are doing slightly different scopes of work, delivering that healthcare. So that's what we're trying to do, and we're trying to think about it in terms of a place to start with. So we're looking at a small place in Melbourne called Cranbourne, through a disease base, so cardiac conditions, and then also a cohort like aged. So I digress, but this is all about sustainability as well. How do we create a sustainable healthcare system for the future? Because we don't have one now. So this is kind of a macro problem, right? And we know that, coming back, why are we doing this? Because we know the carbon footprint of healthcare globally is 5%. In Australia, it's 7%. In the States, it's around 12%, I think it was. And the UK, it used to be high, but the NHS, they put quite a focus on it a number of years ago, and they've got it down to 4%. So it can be done. You can reduce the carbon footprint of healthcare. So sustainability, by design really calls for a focus on the sustainability building block when we're thinking about healthcare and healthcare delivery. Now, I pulled this out of online. It's a tool that's developed by, my glasses aren't good enough now. You can read that. There's a reference there, but basically there are all sorts of factors that you need to consider when you're thinking about sustainability in healthcare. And some of them have already been talked about today. So, do we really need to consume the amount of devices, products that we do at the moment? How is a service delivered? Circularity, so thinking about the way things are made, how they're disposed, can we recycle? So all of these things are things that designers think about, we all need to think about, and things that you'll probably think about in your projects as well. And then just talking about it. I mean, companies are starting to put it on their agenda because sustainability, as you know, it's really critical. Carbon footprint's really critical in our reality of a global warming. Sorry, bang. It's okay, I'll do this. So at MIT, there's a paper that talks about in order to tackle the healthcare system and make it more sustainable, we need to think about different disciplines converging. So they talk about this idea of convergence, which is like collaborating. There's one group in the Netherlands called Convergence, and they're a group from 3 different institutes. So TU Delft, representing the design and engineering design part of the equation. Erasmus University, so it's a health training, a medical training university, and Erasmus Medical Centre, which is one of Netherlands' largest hospital, and they're getting together and trying to rethink and reframe all the stuff you've heard about today. How do we look at things differently? So this is a great image, I think, of a typical inpatient stay, that's all the stuff that's used and that's all the stuff that's going to be thrown away. You know, maybe some of that's recyclable, but probably most of it isn't. Similarly, if you look at, also looked at intensive care, someone staying in intensive care, this is the amount of disposable stuff that is used to take care of somebody in intensive care. So you can see all the bits and pieces, you can recognise them hopefully, and then there's even more. A typical stay in intensive care uses 17 or produces 17 kilograms of garbage. So it's a big, big problem. And since COVID, we know that it's become more of a problem because even more things are disposed of rather than recycled. So it's a big challenge. So sustainability, you know, this thing about talking about it, sustainability is on the agenda of companies. You know, there are companies that are delivering sustainability audits and reports for companies to show how green they are. Some of them are, I'm not saying 3M is like this, but some of them it's really box ticking, but then other ones are really starting to develop real strategies of, you know, how can we become more sustainable? How can we really reduce the carbon footprint in the future? These are a couple of the largest medical companies. You can see this is on their, you know, their webpage as soon as you open it up. So it's really forefront for medical equipment manufacturers. By the way, when we speak to nurses, block your ears, when we speak to have workshops with our healthcare partners, talking about what are the important things for the future of healthcare, what should we be doing, the environment and sustainability just doesn't come up, you know. So because people are at a hospital, it's about looking after people, people first, and they'll just say care comes first. But it shouldn't be able to come at the expense of the planet. We should be able to make it all happen at the same time. And that's why we're here and doing this program. So there's a company that's based in Australia called Multigate, and they produce a lot of the equipment for hospitals, like the curtains, the ward curtains, all of the kits, the IV kits, lots of stuff. And they're really serious about becoming carbon neutral. And I'm going to share a project that they did with us together with Monash Health. So, and Monash Health are really interested in saving lives, number one, but also not at the expense of the planet. So often when we have projects present, it presents as one of the lead clinicians in a hospital. In this case, it was the head of emergency department, the medical department, and she highlighted that IV cannulas, and I was quite surprised about this, 50% are never used. So they're put in people's arms or hands just in case the next clinician. So getting picked up in an ambulance, the paramedic will probably give you a cannula if you're really sick, just in case you need it when you get to the hospital. And chances are it's never going to be used. 1 of 3 stop working completely. And this has got an incredible cost to the nation. It's costing $700 million annually in either treating infections or whatever comes about from it. So the challenge was really, you know, how can we minimise infections and waste and maximise efficiency and compliance? I'll go through that. So I'm going to show you just a few slides from the project, just to give you an impression of how that project went. So it's very summarised. But, you know, the discovery phase, which is what, you know, hopefully you'll be doing in your projects, is really going, looking, understanding what's going on in a particular context. So we started first, before we went and had a look at context, did some background research, see what's going on in the world, to understand the state of play when it comes to IV cannulas. So we looked at the competition, the types of products and the way they're delivering the solution to their customers, to the clinicians. And then we actually went to the hospital to observe how it happens. So the trolley on the left is an IV cannula trolley, and what's on top of it, that blue sheet, that's all folded up and wrapped in a plastic pack and it contains parts that are sterile and non-sterile. Is that right, nurses? Yay! And what generally happens is that's opened up, the clinician will use some of the stuff and the rest of it is just thrown away. So there's a lot of waste involved. So typically, and hopefully this is some of the things you might be doing in the next few days, because I've lost track of time, is when you go and observe what's happening in the context of your research project, you'll be observing what's actually happening, so what the step-by-step, and this is a journey map for the people that are not non-designers. Create a journey map of what's happening in a particular procedure in this case. What are they doing, what people are thinking, and that might come around from speaking to the people that we're designing for, how they're feeling about it, what are the issues, and the issues then offer up opportunities for design. This is an interesting way, or a simple way, to think about, what issues came up and what are the opportunities. So what is the grand challenge, if you like? What are you trying to do? So in this case, how do we guarantee accuracy and simplification of a process, reducing waste and infection, and you can see how that might work, but more about that later. So after our research, we had a workshop with our clinicians, with our engineering partners from Multigate, to look at all the facts on the table and start understanding what could be solutions. One of the interesting things was the cannulisation of the orange. That was very useful for people who were non-medical to really feel how hard that was, as we saw the other day when the nurses were learning how to do it as well. So the summary of the workshop, really came up with a couple of directions around either making things more efficient in terms of simplifying the packaging and reducing waste, and then also around reducing infection by making the bacterial risk more visible. So these are very raw things that came out of the workshop. So you can see that we started to categorise the ideas in terms of, educating people about the process and the importance of kind of not, doing a cannulisation when you really need it was really important, and it feeds into sustainability. Thinking about sustainability, certainty around, as we saw the other day, when you're actually applying the cannula, getting that right feedback. So we came up with some designs that could make that a little bit easier. Patient experience is very important. So I won't go through that. But the concepts were then developed. I'm just going to show you a few of the concepts that came out of it. So one of them, educations, is, it's a really important piece. So we thought, how do we make it more apparent to clinicians? How do we make them stop and go, okay, do I really need to do this? Because this is really going to, there's a risk of infection. So we thought, we got inspired by the smoking campaigns, the smoking packs, and we thought shock advertising might work. So these are some ideas around that would be on the top of the pack. And then some really simple things, like just on the existing pack, just putting some labelling around, hey, stop, this is really risky, think about it. I'm coming up with a new sustainable pack that's in two parts. So there's a sterile and non-sterile part. So if you end up using just the sterile part, you can save the non-sterile part for later, and then using recyclable materials. And then also the patient experience is really important, because at the moment patients don't really understand the risk involved with their IVs. So we wanted to make sure that they can see that, you keep an eye on it, because you're the best person to keep an eye on it, and tell the nurse that, hey, it's time that you took this out or changed it, or, it's hurting me or whatever. So having these sterile strips with graphics on there that indicate the necessity for change. And then also using some printing technology where over time, it changes from being blue and okay to red, so that the patient can see that that doesn't look good, but also, of course, the clinicians can see that it's time to change. And the final one was really just looking around, okay, is that existing IV trolley the right thing to have? Should we have a more modular system where less parts, or you just use the bits you need when you need them? That's it. Thank you.
Thanks for that, Daph. Our next speaker is Dr. Raghu Gudur, and he is from University of Canberra, where he's a program director in interaction design, and he has a background in HCI and understanding the user experience, particularly in the older populations. Welcome, Raghu.
All right, guys. This is the horrible time, as Daphne was saying. So I'll keep it short, try to. And this is very important. Whatever I'm going to talk for the next 10, 15 minutes is all about you. This is exactly what you're going to do for the next 10 days. So listen up, because Leo said there's going to be a flash quiz sometime in next 5 days. Isn't it, Leo? Good. So we have made ourselves clear. So where are we? Oh, that's me. Yeah, okay, now that whole thing is messed up. What happened to the format? Anyway, it doesn't matter. So, yeah, so there's a couple of things happening. My area of research is aging. Look, broadly, my theme is like, supporting aging in place with dignity. It's not just aging, supporting them, but they have their own self-respect and agency. I'm also looking at the second theme is aging with disability. And recently, I'm also getting into the part of human-robotics interaction. That is inevitable. Those machines are going to come, but I want to make them empathized or empathic. That's where the topic is going to. So I'm going to talk about empathic design, which Daphne kind of touched about. I'm also talking about pedagogy of discomfort. There's something which you're going to experience for the next 5 to 6 days at least. All right, so I'm going to put this brief kind of a definition of sustainability. I'm sure all of you know what sustainability is, but I'm a little bit slow in thinking, so I always want some way to define my own boundaries. So I found a kind of a definition that defines me in my discipline. So sustainability is not a zero-sum game, right? So you give and take kind of things. It's not that one is winner, another is loser kind of stuff. So yeah, you can read for yourself that give them, do not damage ecosystem which they are a part of, and provide healthy habitat, and about maximizing our quality of life. I like the last one, maximizing the quality of the life. Also, however, the problem is when we start discussing about sustainability, we tend to look for very objective way to define efficiency, percentage, how to save this, how to save that thing. But we missed out the bigger picture. What if we are doing the wrong thing? We're trying to maximizing or make this current system efficient, but what if this current system is not the perfect one? So I love the last one, that's why I changed it color, So, as I said, there are quite a few things happening in this talk. So that's where the design thinkers and design thinking and designers comes into picture, is that the sustainability is part of the first step of design process, which is empathize or discover or problem definition. As Leo was saying some time back, I don't know who it was you quoted, 95% of the time in design should be spent on defining the problem or framing the problem. So if your problem is innovative and insightful, your solution will definitely be innovative and insightful. They're linked, like the Siamese kids or like quantum thingy. If you know what quantum thing is, but anyway, so problem definition or problem framing is extremely important. Sustainability is linked to that part of it. We don't see sustainability as a separate thing. When we're talking about empathizing, doing user research and trying to understand what is the problem that's really impacting them, sustainability is sticking in your head, the kind of sustainability I defined in the last 2 slides. When the problem definition comes, there's one more thing comes in, which is empathy. Means like, you're not doing this stuff for yourself. There's always a user involved. That's why I keep saying sustainability is not about your own ideology or your way of changing things, but it's someone else. There's a user there and there's an objective or a problem there. You're just the mediator. You're just the channel which you're trying to bridge those gaps. So it's not your own thing. Because I like to do something, you're doing it, but what it impacts, what kind of positive impact it has on the user. So I'm not going to talk about design thinking process because all of you know about it. What's important for is empathy. Understanding what empathy is when you're researching what you mean by empathizing with your target users. Now, the problem is, I've been teaching design thinking for donkey's years, like almost 20 years. One of the biggest things I noticed is that, especially novice designers. So, novice designers is the one who, the day you decide that I want to become designer, you're a novice designer. There's nothing called design student. Because the moment, unlike other professions, we don't go by steps. Even the first semester, you start getting design problem and solving it like a full-fledged designer. That's why we call you, even in the first semester, as novice designers, okay? So for novice designers have the problem to understand what empathy means. Because we easily can grasp what sympathy is, what pity is, but empathy is very hard to get. I can ask you what your understanding of empathy and sympathy is, but the talk will become too long, so I'll leave it at that. So empathy is not sympathy, definitely. It's a lot more than sympathy. You're trying to get into the shoes, under the skin of the user. So, how do we get on this problem? Now, to understand, before I even attempt at teaching someone empathy, we need to understand how a designer empathizes with the user, a mature designer. So designers do empathy aspect of user research very intuitively. You know, with the growing and getting maturity in designing solutions, they do it without thinking. So, however, there are some psychologists. I like Visser. She's a really great scientist. Kupri and Visser have kind of researched about different designers, how they empathize, and kind of capture the process of empathizing in 4 steps. You know, discovery, immersion, connection, and detachment. These are the different stages that designer goes through one way or other to understand or get under the skin of the user. You know, understanding what the problem is. First, the designer has to get excited about the problem. You know, it's all about the emotions. And then they actually get into the context, ethnographic study, how they are facing the problem in the context of their own lives as they get along. And they connect with them, means they talk to them, saying, did I get right? This is what is really bothering you. How significant is this problem? Things like that. There are many stories I can tell you later on, you can ask me, because I also did research with aging with disability. I've seen hundreds of interviews in that one. That is really heart-wrenching, but it's a very good learning experience. And finally comes detachment. This is extremely important. This is where you kind of take yourself away from that experience you had discussing and talking with the users so that you can get into the right frame of mind to solve the problem objectively. All right. I tried teaching with using that framework. It doesn't work because, as I said, people tend to, students, when you're all students, you know what I'm saying, right? So when you have to do any kind of methods things, you look at the methods, and your user is not the one in the brief. Your user is the lecturer, because you want to get a good grade. So although the design brief says this is meant for 70 years old, but it's also meant for Raghu, who's like 50 years old, because he is the one who's going to grade me. So we get into that more. So we need to step out of it and really understand what empathy means, okay? So just following the framework didn't work. So that's where one more thing comes in, which is called pedagogy of discomfort. This is something which I learned 5-6 years back. It was really great because it's not an easy thing, but what this is saying is that it puts students through a kind of a process which kind of, you know, stirs them up a bit in a very safe environment. All of you know how we make memory rest. If I ask you, like, what is the best holiday, it has to have something would have happened in the holiday which really made that memory. So we learn when we are emotionally excited or aroused, means could be a good or bad thing. So that's what this pedagogy of discomfort is trying to do. It is trying to move away from your comfort zone, disrupt your normal process of thinking, and get your attention emotionally, engage. And that's how you suddenly see what the problem is happening with the user. You're not thinking about you or your professor, but you're about the user. So this pedagogy of discomfort is quite very good. Like, you know, it has 3 steps. It allows you to collectively witness, means when you're introduced into a very uncomfortable place, you don't want to be alone there. You should be in the group with someone really curating it. Then you explore with the group, and then you listen to what they're saying and try to get into the whole thing. I know, too much of talking. That's the background. Now I'll jump to the best part. So we did this study over the period of time, but this thing comes from 2019. Same kind of composition, a bunch of students we took to Singapore. Lisa, you're not there 2019, right? Yeah, okay. But you know the same stuff, blog thingy. Some of them were there for theirs. Okay, so anyway, we took a bunch of students there. And in Singapore, we spent 2 weeks. And that time, the theme was slightly different. It's about, like, you know, healthy aging, how to support aging. So a student has to take a design challenge and go to different places of old age homes and things like that and try to come up with a solution. So we try to do both things. We had the 4-step process of empathy and also used situations of discomfort where students have really had to get involved emotionally. So the 4 steps of empathy is like in discovery phase where we go through this whole empathy exercises where you make empathy suits. This is to be normal way we teach design students about empathizing with the user. Like if you want to know about older person, you wear old age suit and you should about to realize what older people feel. But it doesn't work all the ways, But that tells you what it means. What I mean to say is that if you have to imagine that you can't walk properly, you can wear some heavy pants, but it's not the same as the person who actually can't walk for years. They have a completely different sets of problems. It's not just a challenge for them, it's their life. Now that's the difference I'm talking about. So discovery phase lets you know the kind of objective difficulties, means if I don't have a hand, how it feels. But next step, which is immersion, is that which tells you what it means to not have an arm for a long period of time and cope with your day-to-day life. So in the discovery phase, they go through different disabilities a person or aging can cause. Then they spend time with the older people in their own environments. This is quite different, and sometimes it could be really nasty, depending on where you go. And then we come back to the lab and look at all the things. You do journey mapping, which Daphne was telling you, and find the pain points, and go back to the places like old age home where you did your initial research to find out if those problems you identified is exactly the problem which they are also facing, and is it as significant as you think they are. So students has to do daily blogs on whatever they're experiencing, and we got the insights from the blog, like looking at what they faced every day. And did this pedagogy of discomfort really made them realize the problems older people are facing? So I'm going to put some of the clips from the blog, because this is the interesting part. This is going to happen. This is what happened when students actually went to old age homes. This is one of the good ones. So this is a good group. So they visited the house, and this is what she writes. It's a girl, I know that, because she's really good. So being in their shoes really makes you start thinking about how life is truly so short. Yeah, personally experiencing life in center and how difficult it is not being able to have control over your life, certain aspects is just so unnatural. You take it for granted. Now, this conversation I remember, she put in the blog, she also talked to me. She was almost in kind of tears, like she really got disturbed. She was connecting the experience she had in the old age home with her grandmother and how privileged her grandmother was because she's been taken care by her father, things like that. So this completely switched our thing. Now, this is the example that we're looking for. Once you're in the context, right, you're not pitting with them, you're not sympathizing with them. You've seen the older person, you're connecting with your own grandmother, and suddenly everything makes sense. And you realize suddenly, you're 25 now, but in another 50 years, you won't be there, hopefully, but you will be facing some challenges. So that's a good one. And perhaps most surprising thing about their visit was number of elders who just want to talk to a new face. Now, this pretty much every blog has this one. They have this all fancy thoughts. They go to the center, we talk to older people, they keep telling you all the problems and you can quickly fix it. No, they just chat for hours together. And the students are trying to understand what problems they have. They don't have any problems. They're just bored. They just want someone to talk to. They want to see a younger person, and they feel alive when they're talking to them. So again, it changes the complete perspective. I found out very quickly that the questions which they plan to ask, they made a big question, and these are achieving students, and were not as applicable as it hopes, because it said, oh, you have problem here? No, we don't have any problem. Do you get the medicine on time? Yeah, we get the medicine on time. Any wrong things happen in the medicine? No, everything cool with us. So they're all stereotypes. The moment you go there, all the stereotypes are broken. Of course, the relation preconceived ideas suggest might not be work. Again, when the students had to go for the second time, they had these ideas, and when they're, we should have this art class, they already have art class. No, we should take you for excess, they already take us for excess. So again, preconceived, stereotypical, surface solutions are all gone through the windows. Normally, these are the ones becomes final solutions for you, but because you're trying to get in there, you suddenly realize how trivial those solutions are. Of course, we always have champions in our group, like this student group, who can't. They have their. This is the one, right? Yeah. So she hated the cane, but would use it there. Was more stable and safe design. Anyway, the students already wanted to make a cane, walking cane. But nobody wanted walking cane in the center. So they keep on asking questions. So this lady said, yeah, she asked them, like, do you hate this cane? Yeah, I hate the cane. Got it. So we're going to make the cane. So now there's always, if you go with the preconceived solution and you want to push that thing in, it happens. But that's only like 10-15% of the people have. Most of the students very quickly realize, like, once all that preconceived notions broke apart, they come up with some really insightful solutions, okay? So empathy is not sympathy. Empathizing with your user is a lot more engaged, involving, and takes some amount of effort from your side. And pedagogy of discomfort is nothing fancy, as the name suggests. It's just about you need to break away from your mold, and you have to get slightly discomfortable. It's okay to be discomfortable sometimes, otherwise you won't learn. Depends on your capacity. This is a safe environment. You define how far you want to go, but you need to connect with them. You want to feel the pain. It's not just like you acknowledge the pain, but you have to feel the pain. And most of the students very quickly learn. It doesn't take much time, trust me. It's like in 2 minutes, it's just like a snapping off. Like, okay, I'm seated, all older people are saying, oh shit, it's not the same. It happens, it just happens within, you'll get it, okay? So yeah, but this is like 11, 15, 20 students. We need a larger kind of scale to actually do it in a controlled environment in a studio to see how effective this whole thing is, okay? Yeah, that's about it. This is what you're gonna do for next 10 days. So make mood out of this. Thank you.
Thanks for that, Raghu. And then our next speaker is Dr. Kai Chie Lin, Maggie. She is here from Tatong University in Taiwan, where she's the International and Cross-Strait Affairs Director. So come up, Maggie.
Okay, so good afternoon, everyone. Then I'll just represent the Tatong University to be here. Then it's our very first time to just join the program, which the program is designed for change, especially for the healthcare. So in the over past decade, and the Tatong University is trying to just train the students to have the ability to solve the problem, and those problems might be happens in the real world, and which with the complexity. So those complexity might just combine the proficiency from the different fields. So in the past, we are going to trying to just establish a platform for the students from the design and also from the nursing. Then we have the joint course with the National Taipei University of Nursing and Health Sciences. Then just trying to just solve some problems from the clinical scenario by design. Okay, so the case I'm going to just share with you is the latest case we have worked on, which is the design from the umbilical cord. Then the theme of the project, which is called the 脐带. 脐带 is Chinese of the umbilical cord, and also it has a meaning of the expectation. So it pronounced exactly the same, but they do have a different meaning. But I would say like same as in English for us, seems like you do have the beer to drink, you have the bear, it's an animal, and there you have some hair on your face, you will call it a beard. So it's really confused to us, but it's also the same situations in Chinese as well. So, okay, we do have the project then, which is called the 脐带 for U clamp. So here's the content, what we are going to share. Then we start from the background then till the design. Then things like this section is talking about the design process and case study. So I would say that for most of the design process, then we always just start from what kind of issues we have encountered and what kind of problems we are going to solve. Then afterward, in general, we are not the first one to solve a certain issues. So we might have a lot of information can be our reference. Then of course we need to have a clear goal and the guidance to follow. Then afterward will be the design part. So there will be the simple ideas about the design process. So start from the background, and it's always the most difficult part for me, because things like we have some issues from the clinical scenario. So for me, like, which I'm sent with most of the design students, I do have the design background. I do know how to just do the design, but I have little knowledge about what they have encountered in the scenario in the hospital. So for the court, also for the court, we are going to just explore in advance. So every time for this issue, that's what we'll say, like for the umbilical cord, which is a tube-like structure, which is for delivery the oxygen and the nutrition from the mother side for the developing baby. Then after the baby is born, and the cord will be cut, and there is a stump left, and it usually fall off in 2 weeks. So that's the general ideas. No matter what kind of the issues we might encounter, then we need to just get the basic ideas about what we are going to just get rid of. So once we calling about cutting the cord and how, we need to know just how to just cut the cord. So according to the reference, and it mentioned about like there are 2 clamps which we might just lock up on the cord, then we are kind of just cut off between these 2 cords. It sounds very easy, but just try to just have a lot of imaginations to think what we are going to just get rid of. Okay, so where do we just place the cord on the newborn baby? So in general, we say there are at least 1 inch from the newborn, and because if the cord is too long, then it will be just hard to just dry the cord, and it might just easily cause an infection for the baby. But if it's too short, then it will be just really hard to just get some medical treatments of the cord. Then here's a video, then you can see how while we place the cord on the cord stump, then how do we just remove all those the clamp. So as you can see, the blue part will be the clamp, which is really close to the newborn baby. Then they are kind of just grab a scissor, then just try to just remove the clamp, which is close to the baby. So you can see a lot of difficulties on the taking the clamp off. Then also it might just take a lot of time, and it might also take some harm for no matter the baby or the medical staff. So that will be the issues we might encounter, and that's the problems we are going to solve. So this clamp will be the just mostly used globally, but since as what we mentioned, it has been used for the several countries, several people, but is that the best solutions? And that's what we are going to just explore. So there are a lot of information we can just discover, and it can be a reference for our future design. So according to the research, which is just explore the certifications with the cord clamp, and as we can see, like there is a statistic data, which is mentioned like over half of people, they think like the cord clamp, which they do want to have a smaller size because it's easily to just accidentally just detaching the cord clamp. Then they are just worried about they might just harm the baby. And so there is a other design which for the clamp with a smaller size. So as we can see, the cord we see with the blue color, which the length will be around like 6 to 7 centimeters. And for this one, as you can see, the length of the clamp is around just less than 3 centimeters. And it also just can be worked for just stop the leaking of the blood from the just called cord stump. So no matter what kind of a size, from we say the 26 millimeters to the 6 to 7 centimeters, it also can just workable. So as we can see, the future, the soul tube of the clamp will be the critical features on our future design. Then there's the other things that we need to just consider about. So once the clamp which is detached on the cord, then the angle of the clamp need to be the right angle to just to avoid the leaking of the blood. If it's the acute angle, and it might just cause some leakings, and those are the design features, and we need to just consider about in our future design. And not only for those features, but also what kind of the materials and we are going to apply, because things like, it's kind of the trend for the design student now, because everyone just do the 3D printing now. Yeah, because you are just building up the 3D model, then just print it out. This always happen, even a flat plate, our students and use the 3D printing, and that's ridiculous for me, that's why I'll say so. All right, so they kind of just set up the base material which can be used. It will be the nylon material for the clamp, because they do have the natural resilience, the flexibilities of the material, which can just adjustable for the different size of the core. And of course, we are going to just emphasize on people like, wow, this issue is really matters. So we have some more information about like the core clamp market size is more than like 100 millions in 2023 and even doubled in 2030s. So it might be a big market and also important issues on our projects we are going on. Then seems like our students we collaborate with from the nursing students, and most of them work in the hospital. So we get the chance to get some clinical investigation, because of course students are just looking for some answers from the Google that people always do. But sometimes it's really hard to tell is that correct or just only the partial opinions from the Google result. So we get the chance to do the investigation, and we get to have the questionnaires about the safety, and also does it meet your expectations, and how about the videos you have seen before, the removal procedure, is that easy and efficient, and those issues is what we want to just getting to know. And according to the results, there are more than 80% of people think like they met some difficulties on remove the cord clamp. So since there are so many things and we have seen according to the previous reference, then of course on every design, then just try to remember you are going to just set up a clear goal. And of course you are not the first one to do this kind of a design. So it must have some guidance and principles you are going to follow. And afterward, then you are going to just point out some distinctions of your design compared with others. So according to the goal, and we want to do is like we want to have a safety and efficient solutions for the newborn baby to have the cord clamp. So in general, that's what we will say, no matter what kind of issues and you are going to just get rid of, then there is a lot of things and you have no idea where to start, and just try to just ask yourself for several questions. And what is the problems, and who you are going to just design for, and when, why, what, and how. And that will be the basic questions to just answer for your design. So the goal we are going to have the efficiency operation procedures, and to make sure the clamp will be stable, that it won't just harm the baby. And also we are going to just get rid of the size and the weight, and need to be light and won't be too big, and which might just have the direct touch on the baby. And also the cleanliness and also the sanitizer will be the also important part in our design. So there are some principles, like we say the safety, intuitive, which during giving birth, and there is a complexity of the procedure, and there are a lot of tools and you are going to apply. So we are trying to just design the tools can be intuitive use. Then you don't need to just think twice, and you can just follow the instruction on how to just operate those tools. And also the comfort and cleanliness and the reliability will be the basic idea, but it might just vary by the different projects you are working on. Then afterward, then we are going to do the design. And for the design, we are not only to just draw some pictures, build up the 3D models, but we might just set up the experiments to testify, to just verify that's our design, but really just achieve the goal we have set up before. Okay, so according to the previous reference, then we can just set up some dependent variables, which is the length, as what we have mentioned, like from the 26 to like 60 or 70 millimeters, and the angles and the materials we are going to apply. There are two types of the clamp we are going to have. So the first one will be the one stage, so it just only have one lock up, which is similar with the design we do have currently, but it also just might encounter the problems which is hard to just remove. Then we are going to have the second one with the two stage, then we have to buckle up and we have the foolproof design. Then also, like, how do we just verify this? Our design might just work. So we might just set up some independent variables, which we are going to just make sure the tightness, and while we tied up on the cord, and it won't be the leaking of the blood. And also, like, for the time spent on clamping and the removing, and also the easy of use and the preference for those subjective evaluations. So we just combine the no matter objective and subjective to verify the usabilities of our design. Okay, so according to those variables, and we design like almost like 10 samples of the chord plan. And we are going to try to just simulate the situations while the blood flow all the way through the blood vessels. So as you can see over here, so this one, which one we want to just simulate with the cord, then which is pork intestine. Then we are going to have a tube go through into the intestine to just pretend it will be the blood vessel. Then we also have the siren and the siren pump to simulate the flow of the blood. Okay, so first of all, we are going to just check that the environment is okay to the testify. So we just get the original one to testify the validity and the reliability of our experimental setting up. So the blood flow velocity normally not exceeds 90 centimeters per second. So we kind of just set up quicker to just mimic and to operate all those experiments. Then we do really just confirm it's okay to have this experiment, and afterward, then we are going to have our new design then to check the efficiency and also the usabilities of our design. Then here's the video we are going to have the experiment. So we have the clamp on the intestines. Then we have the color liquid, then go through the tube and to check, well, it's tightened up and the blood still just leaking or not. Then we just count the time, then just make sure how many times to tighten up and how many times to remove it. So according to the previous experiment, then of course we might just have some try and error and just explore some mistakes we have taken during our design. So as well we can see over here, so we are going to just place our thumbs, then to press the pressures from over here. So according to the previous video, you can see there is some slippery to just clamp up. So we are trying to have some slippery proof, and also to make sure the width is met, the width of our thumbs. And also we might just have some handles over here, then which is for you to just easily remove the clamp, but also once it's easily to remove, but we are also going to make sure it's tightened up enough. Then we also have the spring over here, which is for adjusting the different size of the cord. Since like it's really, there is a certain range of the newborn baby and a certain size of the newborn baby's cord. Then here's the design scenario, which is we do have the prototyping over here. So things like it's very just convenient. So students are just really do those prototyping, no matter by PLA, SLA, and also this one is from an island, then which is one-time use and to check the reliability of our design. And also here's the view, that's what we want our design will be look like. Then I'm going to have a video to show the whole procedure of our design. Yeah, so in the very beginning, then we are going to just have a brief ideas about what kind of issues and we are going to have, and how do we just set up our claim on the court, then the issues they might encounter, which they need to just remove the claim because it need to just be tightened up. So it's easily to no matter to harm the baby or the medical staff for sure. And also it might just take some time in case in some emergency. So we do some questionnaire survey on the clinical staff, which try to just understand what kind of the issues they might encounter. Then we have the current existing products to getting to know the procedure of the operation. Then afterward, the understanding, then we are going to just start our design. Then afterward, we have the experiments to verify our design. To make sure your design is not only from your imaginations. The design is for the solutions for the social problems with complexity. So there is no leaking. So at least it has the basic functions of the product. So that will be our design. Then we are trying to just trim off some extra materials. That's not only for just light up the product, which things like you just place on the baby, but also you can just do the cost down for the mass production. Then the spring can just adjust the different size of the cord. Then there will be our project that I will say in the following days on your workshop, and you will have a lot of difficulties you might encounter since we do have the students, no matter from the design or from the nursing, then that's what it always happens since we are always just saying something which we are familiar with, but we are not just take notice like others might not understand what you are talking about. So we will say it's not only from the language, but I will say the language might be the issues for us from Taiwan. Yeah, there will be one issue, but the others will be like, since we do have the different background, so you will have a lot of time to do the communication in the following days. So I will say I've done my part. Then best wishes for your next week. Okay, thank you.
Thank you so much for that, Maggie. Now, can I call back the speakers from the session, Raghu, Daphne, and Maggie, to do some Q&A with Leo.
All right, so thank you, esteemed speakers. As per usual, I'm going to open to the floor with your spot-on questions from a student. The expectation is high. So first question, and I have my question ready, but is there any question from audience? Yes, please, in the middle. Can we have a microphone?
Hi, Hi, my name's Maya. I'm from QUT in Australia. My question is a bit more holistic about all the information we've gotten so far. My question is, how can we as designers impact the changes in policy in a more way? How are our design processes and design thinking actually impacting changes in policy?
Hold it.
Okay, thanks, Leo. What a great question. So it really speaks to how you think about design, right? So you can think about design as a tool, as a way of creating a beautiful new product in all of the ways that we've seen today. But you can also think about design as a strategic tool. So some of the things I talked about or shared a tiny bit about when we're thinking about future healthcare, we're hoping to influence policy. And actually, the role that designers have in that project is really to tap into our skill, because designers are really good at bringing multidisciplinary teams together and being able to speak the language of clinicians. We kind of understand a little bit of the language, clinicians, engineers. We can bridge the gaps, and we've got processes to help people, facilitate thinking around really complex issues that then we can maybe create or help people create some proof points that we could then go to government. So that whole thing I was talking about earlier, we're hoping to have a proof point where we make something work in a small community that we can then go to the Minister of Health federally and say, hey, we've been doing this, practicing healthcare in this way, and it's working out, it's efficient. We're not spending more money. It's an efficient use of the funding. So, speak the language of politicians. So that's how we can influence policy, because it's really important to think about things in a different way. Thank you.
Raghu or Maggie, do you want to add? Okay. Second
Thank
question?
you.
Thank you so much for your question. Yeah, Liam on the left. To your right at the back. Oh, sorry. We go with Liam first and then follow up with that. Thank you.
My question, I'm Liam. I'm from the University of Canberra doing interaction design. And my question is for Raghu. It's in regards to aging with dignity. So I would imagine that a person's caretaker would have a lot of influence on someone aging with dignity. So when designing for older adults, how much emphasis would you put on, what's the word? I guess putting yourself in the place of someone's caretaker, like the nurses and their family members and whatnot.
So I hope I got your question correctly. Yeah. So you can't, I would not want to take human away from the loop. So, since you're in interaction design in Australia, at least you're seeing that it's about human resources, limitations, that is pushing us to design to support older people at their places through some sort of digital services. So in terms of designing, right, so what I do in terms of practice is that the distance between the caretaker and the person is increasing. I don't see it as we're removing the human from the loop altogether. That is inevitable. So how I can design technology where the distance is not felt? What I mean is that, there used to be a time when a person was with you at home for an extended period of time. Now it's not possible. But can we bridge that gap through digital thing that although the person is somewhere else, you can still have the same kind of service. Of course, it's not even close to it, but as a person would have been really there. So yeah, when we're thinking about these kind of things, we should never think about replacing humans. I would not want to. If you go to hospitals, you understand. It is scary if there's no human around.
Thank you.
Thank you.
And I think we have time for one more question from audience. There was a question in the center. Resolve. Any other question from audiences? Yep, in the center again. Thank you.
Hi everyone, I'm Mariam from MBRU in Dubai. I'm studying medicine, so I have a bit of a practical question. I'm not sure for Dr. Daphne, I'm not sure if you'd be able to answer, but I was wondering, because you mentioned that 50% of the times cannulas are put on, they're not actually used. Did you guys look into what are those 50% of the times? Like, when are the times that we shouldn't be putting a cannula, but we are, you know?
Question 2. So what we were told and kind of observed is there was this just-in-case attitude. So when patients were picked up, say, from home in an emergency, they were driven to a hospital, and while they were going into the hospital in the ambulance, they were already applied with the IV cannula. And the idea was that, well, they might need it in the emergency department. So there wasn't really a clarity around when it should or shouldn't be done. If a paramedic decided that, gee, this person seems really ill and they might be going, you know, they're going to be admitted, and, you know, if they felt the necessity, they would just do it. And then the same thing happened even in the emergency department with nurses who were triaging patients. They might decide to already insert a cannula without, you know, before the doctor had a look at them. So it wasn't really clear cut in our research. You're welcome.
Thank you. So if there is one last burning question
I have
on the
a
floor.
follow-up question.
Yes, go on.
If that's okay.
Sure.
I don't know if somebody else has a
Yep.
question.
No, I don't see any hand.
In terms of the cannula and the paramedics or the nurses inserting the cannula itself, I was just wondering if this is like hospital policy that they have in place, or did you go to several hospitals and this was the case across the board as a just-in-case thing?
Yeah, and that's a good one too. So the doctor we work with, she's the head of emergency medicine at that particular hospital group, but she's also part of the Emergency Medicine College. So it's a general issue across all of the healthcare services in Australia. So I don't know how it works in Dubai, but in Australia it seems to be a well-known case, and there's literature around the just-in-case cannula.
Thank you.
Yep.
Please,
yes.
So I had an unfortunate instance to be in the ambulance, and I hate needles. Some of the students know that. So they was trying to put the thing in my arm. He said, "Is it necessary? I'm not dying right now." I said, "No, sir, we have to put it because if something goes wrong, your BP will drop, and we can't find the veins. So it has to be inside." So then, yeah, I took it. Like, so that's the reason they gave me.
Well, again, thank you so much for all of the speakers and wonderful question. Please, one more round of applause for our esteemed speaker.
All right, so we're reaching our last session of the day, and we've got some more exciting presentations going up, but we're going to flip the sessions a little bit because our colleague Paul is on the line from Scotland, and we don't want to keep him on the line too long. He's a very important man. So Professor Paul Rogers is the co-director of Design Hopes at the University of Strathclyde in Scotland, and he runs a fantastic research program called Design Hopes, which is directly in the category of what we're doing in our design sprint, and he runs lots of design sprints and challenges across the NHS in Scotland. He's also a design educator that has a long history in design in the UK with many books in his name and many, many papers. So I encourage you to read some of his work after the session. But over to you, Paul. Thank you for joining us from sunny Scotland.
Yeah, nice to be here. Yeah, it is sunny today. I cycled in about an hour and a half ago. So yeah, it's a very, very hot 17 degrees here. It's 8:30 in the morning, so yeah, hopefully everyone's wide awake there. What I'm going to do is I'm going to share with you a short film, first of all, that explains the project. It's quite a significant project in the UK, so hopefully you'll enjoy it, and then I'll show you some slides. So I hope you can see this film.
The healthcare sector is a part of the green transition.
Like all other parts of society, and in response to the pressing climate emergency we all face, it needs to work more sustainably and move beyond net zero. If the global healthcare sector were a country, it would be the 5th largest contributor to climate change in the world. And NHS Scotland has set out its own plans to become a net zero organisation by 2040. Design Hopes is a design-led research project which responds to health and social care needs in order to address these pressing challenges. We work collaboratively across 5 of Scotland's universities, in collaboration with NHS Scotland and other project partners, creating a range of design interventions to help meet and move beyond these urgent net zero goals.
Working with frontline healthcare practitioners, I see every day how much energy our systems consume and how much clinical and domestic waste is generated in a single ward or a single hospital. If you can imagine this multiplied across the whole healthcare system, you can start to understand some of the changes required in our day-to-day work to meet our net zero targets. It's clear there is the will to deliver world-leading health and social care in a way that benefits patients, the planet, and the broader ecosystems we are all part of. There is now an urgent need for us to ensure our health and care services are delivered sustainably. Design Hopes will help us to innovate and change in ways that are tangible and demonstrates the value of these new approaches to patients, NHS Scotland staff, carers, and the wider public.
Design Hopes will advance society's understanding of design's value and impact, as well as some of the behaviour changes and tools needed to transition the health and social care sector to an ecologically and socially sustainable approach.
This project addresses the complex interdependencies of energy and carbon use within the health and social care sectors, alongside other interlinked issues such as waste, resource management, system design, policy, and more.
Design Hopes aims to inspire others, share ideas, and collaborate locally, nationally, and internationally.
As one of the UK's 4 Arts and Humanities Research Council and Future Observatory funded Green Transition Ecosystem Hubs.
We are supporting activities that help reduce single-use plastics, re-evaluate material flows, and model resource management and transport in NHS systems.
Using design to point the way to more sustainable futures and to support NHS Scotland as a progressive social health service in making these changes.
Design Hopes operates across 7 themes: researching, designing and innovating alongside people within Scotland's health and social care sector, small and medium-sized design enterprises, and with NHS leaders, doctors and nurses. This project is using design-led research to show ways to a more sustainable future for the health and social care ecosystem in Scotland, inspiring and demonstrating change which will positively affect not just the health of our people, but also that of our planet.
Yeah, so there's a short film. I'll now show you, we'll dig a little bit deeper now, and I'll show you some slides about the work that we're doing. So hopefully you can see those slides okay. Okay, I'm going to talk a little bit about Design Hopes today. And Design Hopes is the acronym is Healthy Organisations in a Place-Based Ecosystem Scotland, and that's led by myself with Mel Woods as co-director. Design Hopes is one of only 4 green transition ecosystem hubs across the UK. We're a consortium of 5 Scottish universities, but we also work with NHS Scotland and across a number of geographical locations. We also work with industry partners and public sector stakeholders, most notably the Scottish Government. And really the focus or the starting point for our project, which is about a quarter of the way through its 24 months now, is that human health is inextricably linked to the health of our planet and its natural systems. And I think we've all seen enough climate emergency issues across the world in terms of floodings and fires and other kind of natural disasters, and how that impacts upon human health and how it impacts significantly on human health. So in essence, the climate and ecological emergency is a health emergency. But we think that good health and social care can be environmentally sustainable. So as I said, we focused our proposition to get funding on the NHS Scotland and Scottish Government's climate emergency and sustainability strategy. And they have 5 themes within that document: sustainable buildings and land, sustainable travel, sustainable products and services, sustainable care, sustainable communities, and we added two more: sustainable digital design, because digital design is not carbon neutral or carbon free, and also another theme which is more kind of exploratory, experimental, sustainable exploratory projects. And really the ambition of Design Hopes is to embed design-led research and making to accelerate real-world benefits within the health and social care ecosystem. The framework we're using is the Design Council in the UK's Systemic Design Framework. And really that has 4 key stages to it: explore, reframe, create and catalyse. And through that framework, there's a number of activities and opportunities to vision set, to orientate oneself, to make connections and relationships, for leadership and storytelling, and hopefully to apply what we've learned into new products, services and systems, and to continue that journey. And on that framework, we have a number of things that we're doing through Design Hopes. We have 4 design sprints at each of those stages. We have what are called design challenges, where we've just had the first challenge, and we'll look to fund next generation design researchers, so young people like yourself, and we'll give them a significant amount of money to present and to make hopefully change through their ideas. So as I said, we have 7 themes: sustainable buildings and land, sustainable travel, sustainable products and services, sustainable care, sustainable communities, sustainable digital, and sustainable exploratory projects. We'll look a little bit into some of these projects that sit under each theme. So this is within theme 1, which is sustainable buildings and land, which is comprises a number of architects. And one of the projects that they're looking at is the fabric of matter. And one of the things is that NHS Scotland are facing is to look at waste, which is significant. I mean, huge amounts of particularly plastic waste happen every day, every week, every month, every year in NHS Scotland. And as the film said, if the NHS Scotland were a country, it would be the 5th biggest polluter in the world. So there has been a real issue, obviously, with COVID and even post-COVID, with the use of single-use PPE plastics. And some of the work that Andy, a colleague of mine here at Strathclyde, and his architects have been looking at is looking at plastic aprons in particular. And if Andy and his team were only able to recycle just 15% of all the aprons that were issued by NHS Scotland last year, that and rather than divert them to recycling streams rather than incinerate or go to landfill, then they could be used to create plastic architectural products, so things like cladding, drain pipes, doors, floors, and maybe even garden furniture. And you get a sense of 26 million aprons, which would be 15% of the 175 million aprons that are discarded every year, could produce 7,500 plastic panels. But if we're able to do a little bit better than that, then you could see the kind of visualization on the bottom right of your screen that we'd be able to recycle plastic panels, you know, to the scale of the Empire State Building in New York. So really that project is about empowering NHS staff with practical tools and knowledge and processes to implement sustainable practices more effectively, because at the moment things are just discarded and thrown away. Another project as part of Theme 3 and sustainable products is some colleagues in Dundee are looking at a green ward toolkit. And again, they have, through an early kind of pop-up installation, they've engaged staff and medical staff in the hospital about the kind of importance of sustainably and net zero. But one of the things I think with medical staff is, I guess, some confusion over some of the terms that are used. There's a lot of waste that goes on. As you can see in that main image there, that's one ward. That's 1 day of plastic waste in one ward in NHS Tayside. And again, a lot of confusion around terms like circular economy, sustainability, net zero, and the team up there trying to help clarify some of those terms through a green ward toolkit that helps people. Another project within my theme 4, sustainable care, is about making compression work. And that is dealing with people living with lipedema, which is a condition that primarily affects women. It results in an accumulation of fat in the legs and lower body and causes real discomfort and reduced mobility. The main treatments of lipedema are liposuction and compression, but finding the right compression is often, you know, a really difficult and really wasteful process. So some of the existing kind of garments that are on the market just now, again, not incredibly kind of dignified, not really working as well as they could. So again, myself with some textile designers at Heriot Watt are looking to redesign the whole compression prescription process. So starting from scratch and working very closely with lipedema, people living with lipedema and lipedema networks and charities in Scotland. And again, we're looking at how that process might be improved. So not only to kind of minimise the waste or to eliminate the waste entirely, but also to enhance the quality of life for people affected by lipedema. Another project that I'm involved in is reusable theatre caps. And again, there's a significant amount of single-use plastic theatre caps that go to landfill. In one hospital alone, in one theatre, over 150,000 single-use plastic theatre caps are discarded. And again, there are also other issues around communication and misidentification, which this project is looking at. So we've done a number of co-design workshops. You can see some of the outputs here. So one of the things we did was we sent a design probe to find out the kind of people and roles and where they were placed around the body in a kind of operating theatre context. We did a number of co-design workshops that you can see on the right here, where we got people, nursing staff, anaesthetists, surgeons, to design their own theatre cap, what they would like to see communicated on their cap, because we found, you know, communication and misidentification errors can lead to a number of serious issues within the environment of the operating theatre. So really the aim of this project is to address, to eliminate waste entirely, obviously, but also enhance patient safety through better communication and better identification. So we know that one hospital in particular that we're working with in Scotland, they discard well over 200,000 single surgical hats every year. And what we think is that the project that we're working on, it can not only eliminate waste, but it will also cut costs. The reusable theatre caps will also be unique to each member of staff. It will display their name, their role, and that will enhance patient safety and positively impact communication, well-being, incident management, and staff confidence and identification. So we know that 70% of adverse events in the operating theatre are related to communication errors, and communication failures in 30% of theatre team exchanges lead to inefficiency and increased stress, and 4 out of 5 of those misidentifications are reported by female doctors, 80%. So as I said, we've done a number of workshops working in the operating theatre itself, working with nurses, anaesthetists and surgeons. We've sent a number of probes, design probes, to the nurses, anaesthetists and surgeons to get a better sense of what they would like to communicate, where exactly they stand and who stands beside them when they're actually performing an operation, and some of the mechanisms used to tighten the theatre cap. And these are some of the extensive co-design workshops that we've carried out. There's a number of, I guess, kind of obstacles to reusable theatre caps, most notably from the infection control team, but also other issues related to the kind of, I guess, the ergonomics, the comfort, and I guess the performance of the theatre cap. So a lot of feedback about how easy they'll be to wash, which is a significant concern, I guess. Where they would be washed, whether they would be washed at the kind of laundry within the hospital, or whether they would be washed at home. The cost, which we think will be less than the reliance on single-use plastic theatre caps at the moment. But also kind of things like breathable and hair-friendly and lint-free, which are kind of important requirements for the caps. So this project is quite well advanced now. We've been doing a lot of testing, a lot of digital printing, trying to work out the best print, the best ways of kind of putting print onto the cap. Like I said, we're now looking at digital printing as a process for printing these onto a 100% sustainable and biodegradable material that we've discovered. And what we think is the benefit of this project will eliminate single-use disposable theatre caps entirely. These reusable theatre caps that we are designing and manufacturing soon will save money in the long term, and that they will also increase patient safety. So we're in the process of constructing an online enterprise where theatre staff can purchase their reusable theatre cap. They can have some input into the design. We're looking at manufacturing it in Scotland, and then very soon looking at doing large-scale testing across NHS Scotland, hopefully involving around 300 theatre staff and giving them 4 reusable theatre caps. And then that will lead to further design and development, refinement, building an online commerce, and hopefully establishing a new enterprise in Scotland, which will hopefully, in the long term, lead to new jobs. So not only an environmental benefit, but a socio-economic benefit as well. We have other things going on at the same time. Design Hopes, it's a big project. We have a number of community of practice working groups. We have some public engagement. One of our partners is the V&A Dundee, the V&A Museum in Dundee. We're doing a lot of work with Next Generation Design Challenges, which are setting projects like the project you're doing yourselves at the moment. We're doing a similar thing in Scotland. We've just had round 1. It looks like we've got 10 or 11 projects that we might fund. And again, that cuts across all cuts across a range of disciplines, from interaction design to product design to textile design, and cuts across some of the geographies, and also cuts across some of the kind of issues from wheelchair use to stoma product reuse to sustainable packaging for medication and several others. So our team is very large. This is quite an old slide now. There's many more people involved, but it's got a wide range of team. It's a design-led project. So there's architects, product designers, textile designers, fashion designers. Amongst those faces that you see on the screen, we have the director of the V&A. We have the director of a number of product design companies, those that operate within the kind of design economy across Scotland. I think we have around 50 or so people now involved in the project, representing 5 Scottish universities that you can see there, and representing a number of small companies, industry companies, but also public sector organisations, including obviously the important one, NHS Scotland, but also Scottish Government and V&A Dundee. Yeah, if you need any more information or would like to contact me, please do. My email's there, and Lisa, can share the slides afterwards with you. So yeah, just to recap, we're looking at sustainable buildings and land. We're looking at sustainable travel. And each of these projects will have a small team of maybe 3, 4, 5 people working on them. We're looking across sustainable products and services, sustainable care, sustainable communities, looking at land use, sustainable digital design, looking at ways of tracking people when they phone an ambulance and trying to come up with better algorithms for controlling that flow of patients into hospitals through game algorithms and serious kind of game playing. And finally, we have a theme that's looking at exploratory projects, so looking at fairly kind of wacky kind of material, almost on a kind of chemical basis level, at how we might control the temperature of various garments, so whether we're heating or cooling various garments for products for the NHS. So yeah, that's me. I'm happy to take some questions, and also happy for you to send me an email and get in touch. Thanks for listening.
If not, we understand if you got to go off for the day. We have just 2 more speakers left in this session before our last Q&A and the closure of today. So our next speaker is Yassine Hajjat, who's a doctor and the head of innovation and digital health at Dubai Health. He's going to talk to us today about some of the innovative projects that he's working on. So come on up, Yassine.
Thank you. Thanks for the large court of 6 students from BRU for the noise. Thank you so much. Still awake? Still alive? Otherwise, I can get back Daphne to stretch you and make you clap. So it's a pleasure to be here. I'll be talking about, obviously about my field of work, technology applied to healthcare and digital health. And we're going to look at those 2 types of interaction. One, technology itself and the healthcare ecosystem. And the second one being in the theme on how this digital health concept interact with sustainability overall. As part of the journey that you're embarked on, I think it's important to add this angle of, okay, how technology that would probably also be part of the problem can also bring solutions overall to improve sustainability in healthcare. So to set the scene, we're going to start by defining and deep diving into technology in healthcare and digital health specifically. It's a well-established field by now, I would say, but yet evolving. And as always in healthcare, it starts with regulation and kind of strict definitions. 2 of them that I picked up here are with the FDA, the US regulator, or the European regulator as well. But broadly speaking, digital health is technology applied to healthcare. Either it's a software and or a hardware that we would apply for well-being, prevention, diagnostic, all the way to treatment. So that's what would define digital health as a broad concept. Then it gets a little bit more complicated as this slide. As we deep dive, we're going to look at other definitions such as digital medicine, when we have evidence-based technology in healthcare, so we can really prove kind of the impact and the effect, all the way to what we call digital therapeutics. So those are not pills, but they have a clinical outcome that we can measure. And we can also, in some countries, get them reimbursed by the healthcare system. So that's how now technology is getting in healthcare, and this is what we mean by digital health, broader terms, all the way to more specific definitions. Usually when we talk about digital health, we tend to think, okay, it's a smartphone and an app. It's way beyond that, obviously. It goes all the way through the ecosystem. So it's from the IT background of a hospital or a clinic or a GP computer, of course, to the mHealth and the patient-facing solutions, or to the digital therapeutics that I mentioned. Just to make sure that we are not too narrow in that definition and scope, and it's going to be related to our topic and sustainability. So what is this digital health, why now, and how we got to this terminology and field in healthcare? We can go back quite far, but to keep it simple, it would start with the computer and the PCs that came up in the 50s and the 60s. And then we started seeing weird guys in hospitals called IT and IT engineers, and then IT departments. The smartphones brought a new terminology, which is the e-health, and now, in a more comprehensive way, as I just shared, we talk about the digital health. And part of digital health is also the AI and automation and optimization, and that's what we call the fourth industrial transformation. After automation, electricity, and mechanics, we are now in this fourth revolution, industrial revolution, that we are lucky to go through. Talking about the shift and this kind, why we use the word revolution and technological revolution also in healthcare, it's also a shift on the stakeholders themselves. Healthcare used to be a care provider, patient, maybe drug manufacturers, but some of the brands you see here are now full healthcare players. The Googles, the Microsoft, and the Amazons of the world. This slide just shows some of their movement and acquisitions. Now, as a doctor, and some of you are nurses or future doctors, you will be interacting with technological companies the same way you interact with other stakeholders. That's also part of the definition of technology interaction with healthcare or digital health. And if I want to summarize it and narrow it down even more, and maybe looking at it with the angle of the AI transformation, it all goes down to mixing the data and computation elements, and some of you are maybe specifically working on that field, certainly Professor David. This is what now is really shifting the healthcare ecosystem. Through all the ecosystem itself and the players, from the data, the patient, the care delivery, the caregivers, and so on and so forth. And that's really kind of the AI moment that we are also witnessing. Bit of history, black and white pictures. So those are Alan Turing and John McCarthy from both Cambridge and Stanford University, mathematicians, and recognized now as the fathers of AI, or some of the key fathers of AI. So it's a black and white because they started that work in the 50s, but yet they described what we are witnessing today on how humans are interacting with machines that can get like abstract concept and match or even surpass our capabilities through algorithm and models, and we'll get to that. But yet it has been a journey as for digital health and technology in healthcare, back to the 50s, to the moment we see now, where the boom of AI that we are all talking about. And to talk about a boom is a number of applications that we could see. Look at the number of kind of applications that were captured in some surveys back in 2014 on AI, and that boom of 2021. So what happened in 2021? Not COVID, no. ChatGPT. ChatGPT everywhere. And ChatGPT was not just a technological revolution in itself, but what OpenAI did was to bring the technology to consumer level. And this will be a very important concept when we talk about digital health and how technology will transform healthcare. Consumerism, and really the consumer being in control of the healthcare and the technology at once. And also that acceleration and the boom of AI is the technical capabilities, capacity, and the speed. It used to take us a decade or two to match from AI technology human analytical capabilities. It takes only months, if not weeks, to do it now, and most probably a few hours, if not few minutes in the future, if we get to like quantum computing and AI and so on. And all that, again, to set the scene, is what we call the digital health shift. Yes, it's transformative. Yes, it's a shift on the players and the ecosystem, but it's back to the consumer / the patient who will get to the center and take over control the healthcare the same way we did for entertainment or taxi with Uber and so on. Healthcare is no exception. So that's one way to look and define the digital health shift. And it's impacting the whole ecosystem over again. But what you see at the middle is that patient / consumer, and those two words are important when we talk about technology and digital health, that are at the middle to get more personalized experience and take over the control in a system that used to be unbalanced. The patient and the doctor. It's getting kind of balanced, or it will get there. So that was the first interaction, technology and healthcare. Now, what happens when you put it in front of sustainability? And this session is about the challenges. We're going to talk about some of them. This list is not exhaustive. It's a short presentation. But if we want to pick some key principles on healthcare and sustainability, we're going to talk about the environmental aspect and impact. We're going to talk about a very important element of equity in access. And the third one, obviously you know, is the co-design and design elements. We start with the environmental elements and aspects. Unfortunately, the first challenge when it comes to technology and technology in healthcare even more, and related to sustainability and environmental impact, is the lack of awareness. What you see here, can I point? Yeah. So this is a survey, a recent survey from McKinsey, asking organizations, okay, what do you see as a risk, as a threat when it comes to specifically generative AI? As all of us, I have to confess myself, I would say safety, privacy, maybe IP business stuff. It's very, very low to get to think and consider on the environmental aspect of it. It's even worse when we ask the same organizations, what are you doing to tackle those risks? It's the last one. So that it's not obvious. We're still not there to connect the technology and the boom and the hope and the excitement, sometimes even with the risk, the fears. Oh, the first thing we can say, even as a doctor, oh, AI will replace me. But to get to consider the environment and the carbon footprint, it's way too low. If we look at the fact, it's a kind of a contrasted situation. On one hand, technology can really impact positively the overall environmental aspect and carbon footprint. Think about EHR systems, EMR, digitization. We take paper in hospitals and in clinics, and we turn them into electronic records. Positive impact. Think about remote patient monitoring or telehealth. You don't have to drive all the way to the hospital, right? Positive impact. On the other end, if I talk about AI again, to train a very simple, basic model in AI, the carbon footprint is the same as flying from the East Coast to the West Coast of the US. Simple one. If it's a more complex one, it's the equivalent of 50,000 houses for a year in terms of carbon footprint. It's a lifespan of a car, including the manufacturing. That's a more complex AI system. And maybe you've heard some of the AI big players today, because of the energy and the data centers. The Meta CEO, Mark Zuckerberg, was talking a month ago about building his own nuclear plant to power his AI models and data centers. So it's a huge problem ahead. Yet, it's raising awareness as well. Some of the big players like NVIDIA, for some of you, again, who are in the technological side, like when you see now the communication and how they push forward the new GPUs like H100 and so on, they will talk about energy efficiency. But we are far, far from being efficient, especially on the AI and data. Second principle, which is equity in access. This is a paper that I published, I think, last year. I'm happy to share it afterwards, where we try to put a framework on and putting the lights and spotlights on equity and access when it comes to technology and healthcare. Because still, and especially on AI field, it is still for the happy few. How do we bring that technological advancement, especially in healthcare, to all people in need, especially as part of that framework, social determinants, social aspect, communities. And we saw the example of Singapore on how we can connect care with communities. technology can play a role. It's quite disconnected today. The last principle is the co-design. I won't get into details. You are all experts. We've been talking about it the whole day. But while it might sound obvious for all of us in the room, it is not, and especially in healthcare. The principle, the idea of a co-design with a patient in healthcare is not an obvious theme. As I mentioned, we're still in this unbalanced relationship between the knowledge holder, I'm a doctor, I'm a nurse, I know, and the sick person. At least in my generation, we were even struggling maybe to see a patient as a human being. It was a disease or a sick organ, as harsh as that. We made progress, yet we can do more. And there are efforts to bring the design elements, design thinking, into the healthcare ecosystem. This is an example of my university, an MBRU in Dubai. So it's a health science university. We have 3 colleges, medicine, nursing, and dentistry. It's a young university, established in 2016, and 2 years after, in 2018, we've established as well a design lab. So we brought the concept of the biodesign from Stanford to our medical students, and this is our design lab. It was a small one. The university was having less than 30 students at that time, but it was really about putting them in a different framework than the one they used to get in a medical school. They're going to learn about anatomy, cardiology, clinical research, but we wanted to bring back the empathy, the prototyping, the solution, the design, all what we know as an additional framework to our students. And we've been doing that for 5 years, including boot camps in collaboration with Design Institute. Leo came to Dubai a few times. We do it as well with Dubai Design Institute and so on, and engineering schools. So we are kind of forcing that design and co-design thinking within a medical university. And it's working extremely well. And you can see our students here now that are experts in design thinking. All that to achieve, hopefully, some goals, because yet technology and in healthcare will be one of the solutions to achieve sustainability in healthcare, mainly driven by efficiency and optimization across the board. And the true digital transformation in healthcare or beyond is usually this. It's a 5-step journey. 90% of the time, we're stuck here. Why? Because it starts with digitization. It's very simple. It was paper, it's paperless, it's on a screen. Easy, we all do it, needed, good. Full deep behavioral change, sustainability element considered, real transformation as a cultural transformation in an organization or a field, it's the final step, and that's a challenging step, and it includes sustainability, of course. Because it's not only about being digital health or a digital hospital. We start to use this term of smart, sometimes it's overused, but it captures well on, it's not only about turning a paper on a screen, but changing behavior systems deeply. Changing systems deeply means also transforming ourselves. This is another reference to Dubai Health and our university and our organization. We started as a university. We are now an academic healthcare system in Dubai, named Dubai Health. So we are a university, research institute, a foundation, and we have 50-plus healthcare facilities, including 6 hospitals. So we started with the design lab that I shared with you 5 years ago. And as we speak, we are working with Scott and other colleagues in Dubai Health to establish a full innovation center to capture the full kind of spectrum of an academic healthcare system, to serve education first, of course, but also discovery and research, and finally, the care. So we need to reconnect to our patient, which sometimes university is disconnected with as a medical school. So we've started this project. We are now working on the design, on the layout of the floor, and so on and so forth, but making good progress and aiming for an official launch and an event in February 2025. So that's an invitation to bring you all to Dubai in a nice weather in February, if interested. But that's the next step for us. So move from a design lab and really enhance that experience as we're enhancing our system, not anymore a university, but an academic-led healthcare system, and connecting it back to the patient. So really, that's the next step for us. With that, thank you so much. Merci beaucoup.
Thank you so much, Yassine. Very inspiring. And now, last but not least, our last presenter of the day is Daphne Ann Lim, who's the Deputy Manager of the School of Health and Social Sciences at Nanyang Polytechnic, and someone who I've worked with for many years on this boot camp project. So welcome, Daphne.
Thank you, Lisa. After 12 talks and after a long day, I've got the uphill task of summarizing everybody's talk. So I'll try to keep the time. I will. It's just going to take a while. So I'm a nurse by training. I used to work in the emergency department. So I'll try to give you a perspective of the challenges that we face in sustainability from a nursing perspective. So I'm sure everybody was paying attention the entire morning and the afternoon. Which do you think is the industry that produces the most amount of carbon emissions? Of course, healthcare, right? It's been a whole day of talk. So surprisingly, it caught me by surprise because I thought aviation would be the highest, right? But actually, healthcare is even higher than aviation plus shipping in total. So here's the dilemma we face in the healthcare industry. We start by doing good for the sake of our patients. We try to bring health to the sick. We try to add years to the healthy. But while we do that, our patients end up in hospitals or in care centers and they receive treatment. And as if you all heard the whole day, as you receive treatment, we do contribute to a carbon footprint through treatments, the machinery, CT scans that we have to do, and all sorts of medical treatment that come in different packaging that we would end up generating more waste. So with that, we generate more waste, we increase our carbon footprint, and that contributes, again, to increased air pollution, global warming, increase in risk for heat injuries and heat strokes, and then restarting the entire cycle all over again. So does this look familiar? If not, you'll see this next week. This is Singapore, one of our icons, Marina Bay Sands. This was one of the years where our air pollution was the worst because of transnational boundary pollution from our neighboring countries. So the PSI hit more than 300 and all of a sudden, everyone had N95 masks at home. Today, we try not to hit 300. It's been almost 10 years since this happened, so we're very cautious of our next steps. And in Malaysia as well, lots of flash floods in Singapore as well. And forest fires in Australia, getting very common these days as well, unfortunately. So from the perspective of a nurse, I'll try to take you through the journey map of a patient that goes through the doors of a hospital, an acute hospital, for example. So once a patient is admitted to the hospital, there's an assessment that's done by the doctor or nurse. We've come a long way in digitalizing our documentation. We've done away with lots of pen and paper work and lots of paper charts. It's all digital these days, so that's one thing that we've done well in the past 10 years. Then your patient receives treatment from hospital, ranging from medication, nursing procedures, surgery, medical imaging, laboratory tests, and of course the infamous inpatient meals. I'm not sure about Australia, but in Singapore, we always get criticized on our meals in the hospital. They look good, but they don't necessarily taste good all the time. So a study by Singapore General Hospital, one of our oldest hospitals in Singapore, they found out that on average, each patient generates about 1 kilo worth of food waste. So if I have a hospital worth of 350 beds, I generate 350 kilos of food waste every day. And everything that we receive, because sterility is of utmost importance, everything comes packaged sterile. And with every packaging, there's another packaging inside to ensure we don't breach sterility. Even with medical imaging, each of the MRI that you do, CT scans that we do, I totally agree with Daphne Flynn's just in case philosophy. In the emergency department, anybody who comes in with a head injury, alcohol intoxication, everything, we do a CT brain. We do a CT scan of the brain just in case a patient may have fallen and just in case we missed out anything. So the more of these imaging we do just in case, or these procedures that we do, we generate a lot of energy just to get these tests done. And Once we discharge from the hospital, that's where our patients move on from acute hospitals to step-down care or long-term or intermittent hospital clusters. So we've got community setting, GP clinics, as well as polyclinics, where it's really a one-stop shop. We're quite lucky in Singapore because it's such a small country of approximately 6 million people. So it's literally almost at every MRT station, you will be able to see either a polyclinic or a GP clinic, just a stone's throw away from wherever you are. So that's the good thing about small country. And okay, testing my eyesight, it's a bit small. And we've also recently moved on to even switching our medical certificates to electronic medical certificates. You can ask our students from Nanyang Polytechnic, they love it too, because they get to see a doctor through telehealth and get their MC emailed to them. So it's very convenient. So you can see that there's a lot of work done in cutting down paperwork, but there's so much more that can be done to reduce waste during the stay in the hospital, both in acute setting or even in long-term stay institutions. So we've moved a long way from in the 1800s, right, when you visit historical medical museums where a lot of things used to be reusable. So syringes used to be reusable. They used to be made of glass, and they look like those literally from Frankenstein movie, right? But we've moved a long way. Right now, we've moved on to single-use items to ensure that there's a lower risk of contamination from patient to patient, but that also generates a lot more waste throughout the years. On your right, does this work? Okay. On your right, you will see the reusable urinals that male patients can use. And, we've moved on from that to disposable ones made of recycled materials because of COVID. So that kind of spurred on a lot more hospitals to switch from the reusable urinals to disposable ones instead. We have the ones that line the bedpan instead also. So again, to minimize infection and to reduce the work of nurses. Like, we don't have enough to do, right? There's a lot to do already. And yes, and blister packs. So lots and lots of waste generated from medication blister packs as well. So Jie Hong has done a very good explanation of the design of Khoo Teck Puat Hospital, so I'll just really touch and go on this. One of the things that really caught my eye was their rain catchment system at the top of their hospital roof. So it kind of like allows the water from the rain to flow into the pond, and then it generates into a pump to the hospital to irrigate their water plants. And there's so many gardens and roofs that they need water. So the water that comes from the rainwater catchment is really useful instead of actually consuming more water to keep up the greenery in that space, as well as solar panels on the rooftops as well. Okay, so Khoo Teck Puat Hospital, when they started building the place, they had the luxury of considering sustainability while it was still a plain, flat piece of land. So they could take all these designs into place. Another example I wanted to bring up was our older hospital, Changi General Hospital, that's in the east of Singapore. Man, the picture totally covered the Sorry, okay, I'll try to explain verbally then. Okay, so this is a case of then doing something else to a already built environment, because sustainability probably got a lot more exciting after the building was already built. So simple things like converting heat from our existing air conditioning system from the rooftop and generating that heat to supply hot water for our patients in the hospital, as well as other facilities within the hospital that require hot water, like the kitchen, the dishwashing machines in the kitchen, as well as sterilizing your sterile supplies, like your CSSD, centralized sterilizing unit in the hospitals as well. So just this very, very simple idea actually saves a ton. 1,300 megawatts of energy and some 500 tons of carbon emissions per year. Solar panels are also very common all around Singapore's rooftop. So that actually reduced CGH, Changi General Hospital's solar energy by about 4,000 tons, and we aim to hit that in 2040. And as well as a lot of recycling initiatives related to plastic waste. So one of the biggest use of plastics will be in your IV bags or your IV tubings. We have to change the IV tubings the whole IV tubing is every 72 hours. Your IV plugs are changed every 72 hours as well. Everything is made of plastic because we've moved on from leaving pieces of metal in our patients in the 1800s to now, everything is safer and softer plastic. So CGH started collecting plastics in terms of IV bags, IV tubings, syringes, excluding the needles, and they actually collected a total of 130 kilograms of these PVC bags, as well as a total of 520 kilograms of other plastics. And that can be upcycled to create common household products like the garden hose or even PVC, not PVC hose, floor mats. Again, sorry, the picture is covered again. Okay, so the other one is the use of harmful anesthetic gases like desflurane. So we all traveled here. Well, okay, the Singapore team traveled from Singapore to KL by bus, right? So imagine the whole bus ride is just a 1-hour usage of desflurane. So the anesthetists in CGH decided, okay, there is a more eco-friendly version of the anesthetic gas that we can use, which is sevoflurane, and produces a lot less carbon emissions compared to the prior one. So while these are very specific innovations, initiatives that are implemented by individual acute hospitals, the bigger hospitals tend to be very quick to jump on the sustainability bandwagon. And you notice when you visit the other step-down centers as well as daycare centers in the community, they may be not so quick to jump on the sustainability bandwagon. They may need a little bit more help as you observe in their daily practices. So we hope that would give you an idea of what the bigger hospitals are doing, and perhaps there's a lot more to observe in the step-down centers, the nursing homes, the long-term intermediate care settings, as well as daycare centers here. So to summarize, there's lots of challenges and opportunities that we can work on in terms of sustainability in the healthcare setting. COVID has brought about a lot of thought of reducing this challenge of reducing contamination versus the increase in waste as well through the use of consumables. There's also a lot of talk about food waste as well in the hospitals, as well as how we're going to deal with toxic waste instead of incinerating them all the time. Reduction in energy consumption. Singapore is a very, very, very hot country. We only have 3 climates in a year, hot, hotter, and hottest. So we cannot survive without air conditioning. So if that is the general population's comfort level, then how are we going to reduce energy consumption? It's got to do a lot with airflow and design of the buildings as well. Creating consumer awareness is so important. Advocating for change in behavior. We are seeing a change in a generation from one that collects plastic bags whenever they go out to retail and purchase items, versus now the generation is, I've got 1 plastic bag in my handbag and that's all I carry for an entire year before it starts to break. Yeah, so it's about advocating that behavior change, which may not happen overnight, and enhancing built environment, because a lot of Singapore's land is already built. We are a very land-scarce city, and there's so much more that we can think about to promote low carbon emissions in our healthcare setting. Okay, so there's lots of things we can do as you. Not sure why the words are of different sizes. It's not because it's the end of the day, right? It's not my eyes, right? Okay. So next week, actually not next week, tomorrow when we all congregate again in Singapore, Lisa will be sharing a lot on the different themes and topics that we can work on. I hope that today has been a very eye-opening talk, as if I'm closing this ceremony, but no. We've heard of so many challenges from different countries, so many different challenges in terms of culture and traditions. We hope that you will be able to see these in action when you visit the healthcare sites on Thursday or Friday. Yes, thank you, everybody.
Thank you so much for those amazing presentations. Some key takeaways is that digital does not mean no carbon emissions, and that it takes a lot of understanding of culture and also an understanding of processes, and that the healthcare sector is the highest waste-producing industry. So without further ado, I'll turn over to Leo, who's going to do a bit of a Q&A with our last two presenters. I'm not sure if Paul is still on the line, but it may just be with Yassine and Daphne. So go for it, Leo.
Thank you so much. Yeah, I think we have Yassine and Daphne in-house. I'm sure you have many questions. I have a couple. But as per usual, let's just open to the floor. If you have a question, yeah, there you go. Very quick. Darcy, shoot. Just get the microphone and...
Hello. Hi, good afternoon. My question was, I'm Darcy from QT in Brisbane. My question for Dr. Yassine, you gave an example, you gave a few examples of tech companies that are, developing technology that's used in the healthcare sector, and that's obviously a very concentrated market, within the hands of a couple really massive companies. Do you see any risk in having, such a really concentrated, industry involved in the healthcare sector? And do you think there's maybe a possibility for in-house solutions to be, maybe more utilized, or is that not potentially viable as a solution?
Yeah, it's a great question. So my answer will be as simple as yes and no. So yeah, there is always a risk when you have such big firms coming from a totally different kind of background and knowledge and products and coming into a sensitive sector like healthcare. However, because of the technology, because of software specifically, products, we see also thousands and hundreds of thousands of small players, of independent players. It's a very active field for startups. Startups that are born out of universities, that are born, of course, in bright minds, but also in hospitals and clinics and doctors. The beauty of technology is that we can own it. We can easily learn and find solutions on how to develop a software. I'm not talking about complex stuff. Again, maybe some of the AI things are slightly more complex, and even so, we're getting to a much easier aspect. So that's why I'm saying yes and no. Yes, there is a risk when you have such major shift and new players. No, because it's an active field. It comes from all over the place, including the clinicians, including the patient, including startups and universities. And finally, I would add a third thing. Healthcare is regulated. Sometimes it's a problem, but sometimes it's also a safety net. We cannot do anything with healthcare. So I started with the regulators because we are in a regulated field. So yes and no.
Just to follow on from that, if I may, do you think that there needs to be more policy around supporting startups in the healthcare industry, or is that something that you're happy with at this point in time? And obviously that's an international issue. It's not just...
Yeah. The international issue is the unbalanced kind of context. The ecosystem is extremely dynamic in the West, and especially in North America and in certain part of Europe. We need to get it to that level, or at least close enough in other parts of the world. That's the kind of work we are doing, Scott and myself, when we joined Dubai Health, and we are recent to the ecosystem. It's because some regions like the Middle East are saying, hey, we don't want to miss the train here. We want to do not exactly the same thing. We're going to do it our way, but we need to invest. We need to educate. We need to enhance. We need to remove barriers so the ecosystem will innovate and create on itself. We're not there yet. When you see the figures and numbers, you have US far ahead. You have China catching up, Europe regulating, asking questions, but the rest of the world is coming.
Thank you.
Thank you.
Is there any? Yes, Anya, in the center, please.
Thank you. Hi, I'm Anya from Monash University, industrial design student. My question is for Dr. Yassine, and now that we're talking about implementing more technologies and digitalizing healthcare a bit, my question is, what seems to be the biggest challenge for the patients as we are designing for the users, not just for sustainability? We have to think about them as well.
Another great question. And obviously, I'll keep it in the scope of technology and digital health. For me, the main challenge when it comes to digital health and it's related to patient is that we do it all the way wrong most of the time, meaning technologies and solutions are built by engineers, doctors that bring the technology and define it as a solution. And then they go out and look for a problem. Or sometimes force the people to say it's a problem. It's solving something. That's what we try to teach in our design lab and in our class. I'm not saying we're far from being perfect, but obviously, like for you, go back to the needs. The technology is not everything. I am a doctor, tech guy saying that, and I keep saying that in my university to my students, to my colleagues. Technology has this bias where you think you can solve all the problems of the world just because you are able to build a software or technology. But most of the time, you are off target because you don't start with the need. And then we complain, and we see it like in some of the startups, in digital therapeutics and others. They raise money because they keep talking to each other, but then they hit a wall because no one is using that solution. There is no business model to it, meaning you're not solving a problem. That's for me the biggest challenge in digital health. We're missing the point. We're going with technology looking for a problem. Should be the other way around, obviously.
Thank you. Yes, one more question in the center and follow up in the corner. Sure, go for it.
Hi, I'm Daniel Pathamparam from Monash University, Melbourne, and this question is for Daphne. I'm wondering about how, obviously there's a lot of waste in the medical industry, but I'm wondering how, if at all, that waste is sorted or split up into recyclable categories. If that does happen in hospitals or different medical areas, and what challenges come with that, and if stuff isn't separated like that, what reasons are there for that? Why would you not want to think about splitting stuff for recycling?
Thank you.
Thank you. That's a good question. I think from our perspective, especially in the Singaporean society, recycling is still new to us. Even if you're talking about recycling in the home, because of our country's temperature, we can't even set aside food as compost waste. It has to go into the waste and it has to be collected and incinerated the next day. But when it comes to recycling things, it took a long time to get that idea of recycling in the minds, in our mindset, especially in the household setting. So when it comes to the healthcare setting right now, we need to know what materials are recyclable and what are not recyclable. And when we do, it's still manually sorting, and then there'll be a bin that's recyclable and one for general waste, one for biohazard waste. And it's still really up to the user, which is the nurse or the healthcare, the doctors, for them to make that decision to sort and to place them in the right bins. And if they don't, they really get missed and they get incinerated. Yeah, so that's a big problem in Singapore, especially because our landfill, our only landfill, is filling up. And what's next? We're not sure. So there's so much more to do in terms of awareness and campaigning. Recycling in the household only started about 15, 20 years ago when we were starting to get people at home to be aware of this recycling idea. And now that recycling in the homes have increased, now we're looking at recycling in the workplace. So I think if we know, if the healthcare users know what particular materials are recyclable and what are not, that will be very useful, because a lot of the feedback we receive from recycling companies is that they receive things that are not recyclable. And then they end up throwing away because it is cheaper to just throw than to sort everything. So that's one of the dilemmas we face as well.
Thank you. I think we can take one more question. I saw, yes, on the left-hand side, my left-hand side. If you can pass the mic.
Hello, I'm Lindley from UTS in Sydney. My question is if there's any way like the social environmental impact of like introduced systems or technologies can be sort of accounted for before it's implemented and rolled out. Because there's things like the AI technologies, which I feel like have been rolled out quite fast and en masse, but then I think Yassine mentioned as well, like the accuracy issues and also I think like connection between people being lost in those areas.
Yeah, so if I understand correctly, the question is, can we anticipate and put policies and regulations in place before rolling out such technologies, right? Another yes and no answer, if I may. One is ideally yes. Of course, we would like to do that. But if you have a regulation in place that regulates something that you are inventing, you are not in the innovation field. You should go and challenge the regulation and the policies. If you are truly in the innovation space, you should bring problems to the table, which is absolutely fine. The question is, how long do you now then keep those problems growing versus, okay, we get it, we're going to now regulate. The AI is a good example. You couldn't regulate ChatGPT before ChatGPT. It took us almost all by surprise. But now, with the boom, you have policies and regulation like the EU Act on AI. Are we capable today to put frameworks to say, okay, let's measure the carbon footprint before implementing technologies we know? I think that's a big yes, an absolute yes. And that's why we wanted also to bring this topic to you. You will be working and considering a project. Take that one as an example. Think on right away before implementing something, technology or beyond, on the carbon footprint element. That would be a cool project. Because we know what's AI, we know the impact of AI, most of it, so now we can anticipate. But there are things that we cannot anticipate because that's a definition of innovation itself. You don't know what you don't know. When it's there, you fix it.
Thank you so much. I also have one question, which I'm going to make it like A, B, C, D. No, I'm kidding. Like, I really want to ask this question, particularly because this section was about challenges. And we all talked about like the dollar value, the economical impact, even the environmental impact of like what we are facing with technology in healthcare and sustainability. But my question / comment, which I would like to hear from both of you, is what are some of the social impact of practicing a sustainable like healthcare or even embedding technology? And in saying that also, when and where is the right place to start these practices? Because we are all academic here, we are all university students. Do you think, is this the right place to start, or should we have like address and start much younger? I just like to hear from you first, what are some of the social impact of sustainable practice? And in saying that, when and where you think is the right place to start this?
First, is it the right place to do it? Absolutely yes, because we're preparing the professionals and the minds of tomorrow. Obviously, yes. Shall we start earlier? In a lot of places around the world, I mean, in the UK, for example, etc., it's happening much earlier. Where should we take such kind of conversation and discussions? Like in my example in the healthcare system, is to the patient, is to the bed, it's to the ward, which we're still missing. Again, before we were just university, so we were focusing on our students, we equip them with a framework, and all the best. Now we are an academic healthcare system, and the whole point of this innovation center that I'm trying to establish is to say we're going to try to close that continuum and connect it back to the patient and to the needs. We start from there, and we bring it back there. This is, in my ecosystem, the missing piece of the puzzle that hopefully we will be solving soon.
Thank you, and Daphne.
The short answer to your question is to go back to our cyclical dilemma about treating patients and then generating waste, and then again harming the environment, and then people get sicker and it doesn't end. Patients also keep coming back for the same problems. So if we can cut down on our emissions, talk about sustainability in terms of healthcare, not just in terms of waste production or carbon emissions, but also, I think, in terms of sustainability, in terms of manpower, right? We don't have enough We have an aging population, aging faster than we can produce more healthcare staff to take care of patients. So if it can break that chain, perhaps it could definitely have an impact in readmissions in hospitals. Finally, we can dream about catching up towards having enough healthcare for our aging population. Because right now I'm sure in many countries we're still catching up.
Same in Australia,
yeah, we can't catch up. So hopefully we can reach that dream faster. Yeah, in terms of having enough healthcare for everyone.
Very well. With that, thank you so much,
Thank you.
Yassine and Daphne and Paul.
Wow, what a day. I hope you guys are inspired to make new design solutions. One of the key takeaways that I have from this day is that when we talk about artificial intelligence, it's artificial. It's artificial intelligence. We are humans in the world. We are creating this system of artificial intelligence. And what artificial intelligence cannot do is understand a human experience in the world. What makes us human is our culture. And here we have so many different cultures represented. So take this opportunity to learn from the different cultures. You've learned a lot about Malaysia in the last couple days. You're going to learn a lot about Singapore. But within the universities, we brought you from different cities. All those cities have different cultures. A lot of people, your parents are born in a different place or you're from somewhere else. So take this opportunity, not just to look at this problem that we're posing you, but to open up your eyes to other cultures, because the only way we're going to solve these problems is with that cultural understanding, so that we can have a universal acceptance of products, service systems, or awareness campaigns. So without further ado, I'm going to introduce you to the Executive Dean. We did meet him on our very first day, but Professor David is here. He's the Executive Dean of the Faculty of Innovation and Technology here at Taylor's, and he's going to close off our program, and then we're going to have some afternoon tea back upstairs. So you can network a bit more and ask the speakers for some questions, but please welcome Professor David.
A very good evening to all of you. I mean, the staffs, the students, okay, ladies and gentlemen. You had a whole day presentation, and yet I see all of you very lively. What's the secret? Maybe it's the commitment and the interest in this area. All right, I hope you all enjoyed this session, all right, the symposium. We live in a world that is continuously being polluted and destroyed by whom? By us, all right? So not only we need to be aware of the issues and problems and come up with solutions, there is a need to develop various solutions. And that's where we have brought people from all over the region, okay, to come over here, interact, and look at a solution that can fit into the whole world, right? It's not just for one region, but we come up with a solution that can can be used across the border. So that's one of the purpose of this symposium. There was some great presentation from the staff. Okay, I think we need to give a round of applause to all the guest speakers. Yeah. I was listening to some here. I was also listening online. I was also sitting when I was doing my work. I was looking at it online. Good presentations covering many areas in the area of healthcare. There is a few things that we need to understand besides having sustainable solutions, looking at real world problems to solve them, and so on. Another thing is the change of behavior. I think one of the speakers brought it up. We all need to look at how we can change ourselves. For example, if we take, we need to start using less. What do you mean by that? We need to use less of our textile, less of the water, less energy, less transportation, etc. Give you a simple example. Textile industry is the second or third world pollutant, right? And how many of us here have more than 50 pairs of clothes, shirts, and so on, including me. Yeah. So we need to learn to use less. We need to learn to be aware of the world, and so that this world is shared by everyone. Therefore, we need to use less of it. Right. So that's another change in behavior that is required. Okay. Since last Friday, I think you all have worked very hard. Okay. You have looked into various problems, solutions, and so on. Okay. And I think it's an opportunity. I think what's more beyond what you have participated in this session is that you carry back a network, a friendship among all of you. All right. This network is very vital. All right. Very important, because 20 years from now or 10 years from now, you may have a solution that you may want to share with people from different countries. And here is your contact. The contacts are here. All right. And you can share with them, one day. And believe me, when you do a startup, and if you want to expand your business, right, you could also use the channel or the network today. So make sure you get to know everyone here in this room, and at the same time enjoy, the sessions here. I would like to, as the Design for Change symposium comes to a close, I would like to thank a few parties here. First, the academic staffs, from all the partner universities. Thank you. And the students who chose to be here. A round of applause to you too. And we have an entire team that helped to organize this event, including Prof. Lisa, Khairul, and all the technical team here. A job well done. Well, I understand that you will be going to Singapore tomorrow, right? Have a safe trip, and have a safe trip back home as well. And enjoy. Thank you.
I just have a quick announcement before wrap. This QR code is a survey about the symposium, and we would love to strongly encourage you to just take a part on this survey. It would help us to know what to do better in the future year. Thank you.
Thank you. Yes, so please go up and have some afternoon tea, and we will also inform you of when the coaches will be going back. We will have a photo of everybody too, so I will let Yusri organize this photo, because he is the professional photographer, or the photographer will tell you what to do.
I think we have done this once before. If I can ask you kindly to get to the center row or center column. So I want everyone to gather in the center. The left and right wing, if you can just come to the center, that would be amazing. Center. The